Check 1 2 1 2.
Good morning. Good morning. Can you hear me? Ezekiel, can you hear me? No. Okay. It's not. Yeah. All right. Good morning. Can you hear me? Okay. Good morning, everyone. Good morning. Good morning. Still can you hear me? Good morning. Good morning. Okay, there we go. Good morning. Hi, everyone. Good morning. Thank you all so much for being here this morning. I always hate to interrupt great conversations, but we are here for the Health Equity Symposium, and this is a long time coming, both from a planning perspective and from a years-long legacy in this department. So just want to get things started off this morning. We have an exciting slate of speakers today, some really great alum who've come in from all over the country to share their work with us. We'll hear from our faculty and staff and students here in the department. So it'll be a really, really great day. So first to start things off, I'm Daryl Hudson. I'm the chair of Health Behavior and Health Equity. So first of all, I'd like to thank you all for being here today to celebrate such a significant milestone in the history of our department. It's with great pleasure and excitement that I welcome you to the symposium. I want to also extend my heartfelt gratitude to everyone who has been a part of this journey, particularly our symposium planning committee. Like I mentioned before, this is a long time coming, so all the efforts that you all have made, particularly Jenny Crawford, Chris Bowling, Sarah McCain, Ezekiel Medina, Akila Patterson, Scott Roberts, and Amy Schultz. Thank you all so much. Can we give them a round of applause? As I mentioned before, we've got lots of different guests who've come in to share with us today, so thank you all for being here. And thank you all in the audience who've got a nearly full auditorium today, hoping to keep you and engage you throughout the day. I also want to acknowledge Professor Emeritus Cleo Caldwell, who's not here today, but is a driving force behind these efforts. So I worked with Cleo many years ago, like many of us did, and she made such a mark on many of our students and our community and the contributions to the general field as well. So just want to acknowledge Dr. Caldwell, who's not here, but is really responsible and has a large push behind the name change. So if we could give her. All right, and it's not just Dr. Caldwell, however. There's many people in this room and who are not in this room who've made substantial contributions to the department. In the legacy of HBHE, from Arlene Geronimus and the Weathering Hypothesis to Kathleen Collins' contributions to chronic disease, to Mark Zimmerman's work around youth violence prevention and empowerment. There's so many people in the room, and then people who are not in the room, like Neil Krause. People remember Neil Krause? And the stress, understanding stress and aging, Woody Neighbors, my advisor, Rashid's advisor, who's responsible for many of us being here in the first place, and then also his contributions to mental health. We've got Vic Strecker, who's made outstanding contributions to health communication, Amy Schultz and Barbara Israel's pioneering work in community engagement. I can go on and on and on, but I think you all get the point that although the name is new, the contributions of HBHE faculty, students, and staff is not new to this space. So thank you all for your contributions. For this next phase, collectively, I believe that the hard work and passion and dedication of our community will continue to lead and inspire the field of public health. So, for many years, under the name of health behavior and health education, we've been at the forefront of public health through rigorous research, innovative education, and impactful community engagement. We strive to understand and improve health behaviors and to educate the next generation of public health leaders. So as we've progressed over the years, it's become increasingly clear that health behaviors and educating our communities, while critical, is not quite enough to tackle the complex contemporary public health challenges that we see. Health disparities persist, and in many cases are growing. If nothing else, we can look at the latest pandemic and see that there's ongoing social and economic inequities. So that has underscored the need for the important equity work that we do in the department. So this name change, health behavior and health equity, reflects our renewed and intensified commitment to this cause. This name change is not simply rebranding. It represents our department's evolving mission and core values that we hold. So by explicitly incorporating health equity into our department's identity, we're recognizing the pursuit of health for all cannot be separated from the pursuit of justice and fairness. We're affirming that health disparities are unacceptable, unfair, and are dedicating ourselves to the fight to eliminate them. So I would say our vision collectively in the Department of Health Behavior and Health Equity envisions a world where health inequities across race, ethnicity, socioeconomic status, geography, gender, sexual orientation, ability status, immigration status, and other key social factors are eliminated. Through interdisciplinary collaboration, innovation, and equity-centered practice, we aim to cultivate a healthier, more just society for all. So what does that mean in practical terms? In practical terms, this means that our research will focus on identifying and dismantling the structural barriers that prevent people from achieving optimal health. It means that we endeavor to address multi-level health behavior challenges and strive towards equity through rigorous, impactful research. It also means that our department will prioritize collaboration, capacity building, and adaptiveness, ensuring that we remain at the forefront of health equity for all. We challenge ourselves not only to create new knowledge, but to make sure that that knowledge is translated effectively and disseminated in an accessible manner so that those who need it the most can receive it. So to do this, we are committed to fostering a diverse, inclusive, equitable environment where diversity of identity and thought are not only valued, but actively integrated into our research, education, and community engagement. On the educational side, we aim to develop and implement innovative curricular approaches in order to provide students with knowledge, skills, and experiences necessary to address complex public health challenges and address the root causes of health inequities. So we know that equity-centered, sustainable solutions require effective community engagement, and we're so fortunate to have a great speaker to talk about that in just a moment. So we are committed to intentional, authentic community engagement, fostering partnerships that uplift and empower. We recognize that these goals are very ambitious and that the challenges and barriers are steeply stacked. Nonetheless, I believe that collectively, we can make significant strides towards these goals. But we need everyone to join the fight. How do we do this? I'd like to call out a few texts that I've been reading and have read recently that provide some foundations, if you will, some best practices that we love to talk about, right? So the first text that I'd like to highlight is a book called The Four Pivots. Anyone ever heard of that book? Four Pivots, a few people. This is a book by Sean Ginwright. It's called The Four Pivots, Reimagining Justice, Reimagining Ourselves. So I won't spoil the entire book, but one of the key premises, one of the key pivots in that text is that change can't happen without healing. Change cannot happen without healing. So many of us are wounded warriors. I can think for myself, growing up in Detroit, a lot of the health inequities that I study, the factors, the economics, et cetera, happened to me. And so I have to think about how do I separate what's happened to me and heal from the slights that I've experienced to be able to more effectively engage with others so that we can come up with effective solutions. So Ginwright argues that it's critical for us to examine ourselves and process the harms that we've endured in addition to raising our own self-awareness. And by prioritizing our healing, we can engage in more sustainable, transformative, justice-centered work. Another pivot from Ginwright is vision over problems. Now, I remember when I was a student here that we talked about problems a lot. Is that still true for students now? We spend a lot of time talking about problems and analyzing problems. Ginwright encourages us to envision possibilities rather than just what he calls problem loving. In other words, can we imagine the possibilities, the radical possibilities that there are by reframing equity as an opportunity to unlock untold potential of people who simply just need an opportunity. And I think about kids like myself, growing up in the city of Detroit, just needing an opportunity to get my contributions out. So I challenge you all, what does a healthy, equitable, thriving future look like? Let's try to prioritize that over just the analysis of problems. The next thing I'll mention, and this is, I wish I had a Michael Buffer voice, but I don't. Let's get ready to rumble. Get ready to rumble. This is from Brene Brown's Dare to Lead. Anyone read that book before? In this text, she challenges us to have real conversations, even when they're hard conversations. This means that we have to prepare to engage with each other, requiring vulnerability, courage, and openness. So in our department, it means that we have to check our egos and be willing to listen, learn, and grow. We have to be willing to embrace the discomfort of not always having all the answers. Indeed, I always say that if we had all the answers, we'd probably be out of business. So it's important to think about that, getting ready to rumble, so engaging in that process to engage with each other. Another text that I like to highlight is a book called The Sum of Us by Heather McGhee. Anyone ever heard of that book? It's a really good text. One of the key premises starts in St. Louis, where I just moved from. There was a really massive pool called Fairground Park Pool in the city of St. Louis. And people said it was so large that you could see it from space. St. Louis is really hot in the summertime, really hot and humid. So you'd imagine that having a cool pool to cool off in would be a great addition to the community. Around 1948 or 49, there was a move, like many places across the country, to integrate the pool. And in the aftermath, when the first black swimmers showed up to swim, there was a massive riot. That still resonates in that community today. Heather McGhee describes how this incident wasn't just unique to St. Louis, but happened all over the country, in which people would rather fill pools with concrete rather than to have an integrated swimming pool. They're in drain pool politics. Many people would rather take resources and hoard them rather than to share with others so everyone has an opportunity. So McGhee encourages us to unplug drain pool politics. So I think that's important for us to consider. What ways can we actively think about unplugging those pools? The other thing I'll mention really briefly is, and I think this is a good way to think about unplugging drain pool politics, is Angela Glover Blackwell's curb cut policies. Anyone ever heard of a curb cut policy? Just a couple people. I met Angela here in a long time ago. I won't tell you how long ago. When I was a student over in the league, Michigan League. And Angela describes policies that often center on people who have the least, but benefits others. So the analogy is that imagine if you were in a wheelchair and you were making your way down the street and you got to the end of a street and there was a curb, but there was no ramp for you to easily navigate down to the street level from the sidewalk. What would you do? Not a rhetorical. What would you do?
I'd ask for help. Someone needed help.
Okay. So remember context too, right? So we have to think about where we're at, what time of day. You know, if you're in New York, could you ask people for help? I don't know. Yeah, people are kind. I'm just picking on Brenda. I'm just picking on Brenda. People are kind in New York. And I see Mark glaring at me from New Jersey. The New Jersey contingent over here.
New Jersey would, I mean, New Yorkers would definitely have helped that person. Yes.
So the point being, you can wait for a kind stranger to help you. You could risk it and go over the curb. So thinking about Brian's work around risk communication. So you can go over the curb and risk damage to your chair and yourself. But what if society places a curb cut? If we put a cut into that sidewalk, it makes it easier for that person in a wheelchair to navigate. But not only that person in a wheelchair, but also a person on a bicycle. I'm sure some people you're not supposed to ride your bike on the sidewalk, right? But for those of us who have occasionally found ourselves on a bicycle on the sidewalk, it's a lot easier to go down the curb than jumping off the curb, or to go down the ramp rather than jumping off the curb. Same thing for when you're traveling and you've got luggage, right? You can hear that crunch of the wheels when you pull it off of a curb. So that curb cut benefits you as well. So in that way, Glover Blackwell challenges us to think about curb cuts so that we can dismantle this notion that equity is a zero-sum game. Rather thinking about ways that equity benefits everyone. Because at the end of the day, in the health behavior department, we all think about things from a selfish notion. So how can we find things that benefit us all? So curb cuts might be a way to do that. So all of these approaches require us to get ready to rumble, as Brene Brown would say, to engage with discomfort, biases, and hurt in order to show up ready to partner, to work shoulder to shoulder with people who are like us and share our values, as well as those who we might be a little bit more skeptical of. These approaches mean that we have to be prepared to reframe equity so that people understand what's in it for them, and that equity is not a zero-sum game, where you simply take arbitrarily from one group and give to another group. So that being said, there's some exciting things happening in the department. I'm not allowed to share just yet, but in just a couple weeks, we'll have an announcement about a really monumental opportunity that will cement the university's commitment and partnership in working with communities to achieve health equity. We've also like to highlight a really generous gift. Where's Barbara at? I'm going to embarrass Barbara. Sorry. I'm going to embarrass Cleo too. We were talking about you before you came in. So thank you for joining us today. So Professor Emeritus Barbara Israel has really decided to pay it forward, establishing the Barbara Israel Endowed Internship Fund. This will be used to support the next generation of community-engaged scholars. Barbara's also contributed to the Detroit Urban Research Center, which turns 30 years old next year, which is now under the capable direction of Dr. Enrique Neblett. So Barbara, thank you so much for your support. Not just your support there, but also your many contributions to the field, being a pioneer and pouring into so many students in such a humble manner. So thank you so much. I'd also like to embarrass Cleo too. I was embarrassing you before you came in, but I'm going to embarrass you now. Cleo also set up a fund as well, a scholarship fund for students, again, underscoring her commitment to the next generation of scholars, and not just, again, your support there, but the many contributions that you've made and how you've poured into so many people. So thank you for your contributions. All right, so I've probably talked too long, but we really appreciate you all for joining us in this struggle to address complex factors related to the broad fields of health behavior and health equity. As we embark on this next chapter, let's celebrate our achievements today, embrace the challenges ahead, and reaffirm our commitment to health equity. I certainly am excited about the future, what the future holds, and look forward to the impactful work that we'll do together. So next, I'd like to bring to the podium Ms. Ella Greene-Moton, who's our keynote speaker for this morning. Ella is the current president of the American Public Health Association. So it's truly a treat that you're here with us today. We worked together way back in the day. We were talking about over dinner, working in Flint under the direction of Mark over there on youth violence prevention, working with youth. Rashid did that too. And I can tell you that Flint, even from being from Detroit, Flint was eye-opening for me in how I thought about health equity, social determinants of health, so on and so forth. So again, thank you for your contributions. Ella has been a pioneer in community-based participatory research and programming, working over 40 years in the city of Flint and surrounding areas. She's facilitated many different community academic practice partnerships. She's worked as a community-based organization partner, Community Ethics Review Board administrator, and the executive consultant and co-chair of the Flint Genesee Partnership Health in Our Hands project. She's also served as an independent community engagement consultant, working with many different national academic institutions, again, to promote community-based participatory work. I'd also like to note that Greene-Moton is the first non-academic professional to serve as the president of the American Public Health Association. So what a treat for us to be with you today. Also, to embarrass Ella, it is her birthday. So can we, happy birthday, and thank you so much for being here. So.
Good morning, everyone. Ooh, that was a good one on the first try. You guys have been trained well. I am so honored to be here today with you guys, with folk that I've worked with for, I like to say, 100 years. Some of those folk being responsible for me being where I am, giving me that first nudge, or even noticing a quiet person sitting in the corner, maybe looking like she wanted to say something and not knowing how to and not feeling comfortable enough to say it. I just being with everybody last night brought back all of those memories on, honestly, the real reason that I ended up where I am today, and being able to sit in the role of president of the American Public Health Association. So I'm gonna say this, that I feel like, not because of me, but I feel like that's a big deal, because that's not something that many community folk can even think about having happen to them. And I'm gonna take it a step further. Not only am I the first non-academic, I'm the first non-academic, non-practice, non-degreed person in a 150-year history of APHA to serve in that position. So I am so honored to be here. And do I say next slide, please? Okay. So guys, being in the position of president, and I'm gonna apologize too for sitting, because he mentioned that today is my birthday, and it is, and I've never been ashamed of the years that I have accumulated. So I like to say it in honor of all the old school folk. I turned 76 today, so I'm honored. But recognizing that APHA is the national voice of public health, it's been an honor to just be there. When I first went in the early 90s, I went only to present. Academic partners needed to take their community partners with them so that they looked authentic. Some of them were, some of them were not. But I was introduced to APHA that way, going to present. And me being the person that I am, it struck me that this place is too big for this only to be about us coming here to present. At that time, there were like 50,000 members, or right about. And my question was, where are the decision makers? Where are the people making the decisions in this joint? I want to know them. I want to get to meet them. I want to work with them. So I literally set out to do that. And Mrs. Ehil Deloney, who many of you knew, was my executive director. And she allowed me to drag her around to the governing council meetings. We sat in the peanut gallery just to see what that thing was all about. But it was important to me because I knew there had to be a lot more going on than just going to APHA to present. And I was lucky enough to find the action board. And the door was closed. And in my mind, they were tucked away in the basement someplace. Now, they might not have been, but that's the way I remember it. I knocked on the door and asked if it was a closed meeting. And she said, no, would you like to come in? And I said, yes. And I went in, and I stayed, and I liked how they were having those conversations. And I stayed, and I kept staying, and I ended up becoming chair of the Action Board, then a co-chair of the Joint Policy Committee, then a member of the APHA Executive Board, then running for APHA Executive Board, and on and on and on. But because I had the drive, and because folk like you, the folk that I've worked with over the years, actually put that drive in me to make me wonder, to make me want to do more. And I just appreciate that. But recognizing that APHA is the national voice of APHA, I have to give APHA its just dues. And I'm thinking that if all of you have not had an opportunity to go to APHA, I'm hoping that you will. I'm excited, well, maybe a little less excited this year because this year I give up the presidency, so. But it's been a lot of fun, right? So that whole process is a 3-year process. The president-elect, then this year is my presidency, and next year will be the immediate past president, where I'll get a chance to really actionalize some of the stuff that we've talked about and some of the other things that we've thought about doing. But I'm hoping that you'll get a chance to go, and if I can give you just one piece of advice. So back in the day, we used to get those books that were about that big. I don't know, maybe 1,000 pages. I don't know how many pages. But they're not that big anymore, but don't allow APHA to be overwhelming. That used to really bother me when I would hear people say that. APHA is so overwhelming. It doesn't have to be, because the reality is you can't do it all. And all of it is not meant for you. Do the pieces that you can do. Learn from those parts that you can learn from, and allow it to be an experience that helps you move forward with what you intend to do. Meet new people. Keep those relationships going, because I'm big on relationships. And I think if you're not now, push yourself. You need to get to know folk and know that it's not just about who you are and what you know how to do, but it is about those relationships that you create and those relationship-oriented partnerships that come about from those things. So take advantage of the opportunity if you are able to go. Next slide, please. And so just talking a little bit more about APHA and the initiatives, I don't know if you've had an opportunity to take part in any of these opportunities throughout the year, different times of year that they take place. And most of them I have had an opportunity to be a part of, but the one piece that I really love would be the Hill visits. And I would encourage all of us from our individual communities, from this community here on campus, to find a way to do Hill visits and talk to the legislators and share with them your concerns. And also make it a point that you don't just wait until you need something. Go just to say thank you. They remember that. But look at the public health initiatives and be active. Take part in these activities. I have learned so much from all of them, and especially the racism as a public health crisis declaration. Our state affiliate submitted one. Many of the affiliates across the country have done that. This is a way of you really understanding how racism shows up in these different spaces. But all of these are public health initiatives, and they are available to you to take part in different parts of the year. And I would advise or encourage you to take part in those. Next slide, please. Also here, we're talking about things that additional public health perspectives, but health in all policies is something that we take very seriously as well. And I don't know why I never thought about it before, but just recently I've started to think about how important voting is for health. And I don't know if we didn't say it like that earlier, but it didn't resonate with me. But we need to help people understand that our votes determine a lot of what the health outcomes are in our communities, because the votes determine who is in office, who's making decisions, what policies are passed, what policies hinder us. We need to think long and hard about that and allow that to be important enough to do your civic duty and vote and encourage other folk to vote. But just understanding that it impacts all of these things: housing, transportation, education, healthcare, and the environment. Next slide, please. I wanted to share this slide because, again, talking about the national perspective, and I like to call it the power of possibility, because I still say, you know, when I think about it, my even being asked to run for president of the American Public Health Association, because I've always held APHA up here. And when I got that email, I didn't realize they were asking me because I didn't think I was qualified. It took me 2 or 3 times to read it to understand that they were literally asking me if I were interested. I literally thought they were asking me to give them names of folk that they could ask, because that's what I do. I push other people forward, right? And when it finally hit me, oh, wait, they're asking me. So I had to call Mrs. D. It's like, Mrs. Deloney. And then I called my other sounding board, Arlene Sparks, those 2 ladies. Hey, when I've got some decisions to make, I can call them and talk to them. But the idea that it was being offered to me, because still, I know that not being, my being a non-degreed person doesn't sit well with some folk. But I have to tell you, it's just a personal thing for me. I love learning, and I'll be honest with you and tell you I'm good at it. I like making A's, but there were so many other things I wanted to do. And I was never raised to think in terms of going to college to get a degree. I was born on a cotton plantation in the Mississippi Delta. I worked in the cotton fields. My first job was $2.50 a day. So my dream was to get the heck out of Mississippi. And I did that. And I was okay with that. But I realized how important it is to get an education, to move on. I have a son who has a PhD designation, and he actually serves as superintendent of schools down in Jackson, Mississippi. Right? So it is important, but it's just a personal thing for me. Now, I tell people, I was supposed to do it when he did it, but I got busy, and he went on and got his, and I couldn't do it. I say it might end up being my exclamation point. And if it's not my dash, I'm okay with that, because I'm happy where I am. I love what I do, right? But accepting this position, I had to make some decide what was going to be, I had to decide on things that I wanted to work on as president. And so these are 3 of the areas that I really wanted to focus on as president. 1, strengthening the public health workforce. And for me, it wasn't the training that the current workforce needs. For me, it was looking at those young folk who are in high school, junior high, and elementary school, to expose them to public health, to help them understand what public health is, because that's another problem. Many of us don't even know what it is. That's why we can't get in tune with it. So maybe we need to get our brains together and come up with a really good short something, because people are still trying to figure out what, for me, it's everything. I can just accept it like that because I haven't been trained in any discipline, so everything is on the board for me. But thinking about how do we get young folk engaged in wanting to be part of public health now, before they've gone through high school, want to do all kinds of other stuff, and how often do you hear folk, once they get out there and start doing something, they hear about public health and wow, they want to come back. And also working to help it more beneficial to folk who are in it. I would be one of the first ones to say that we're not respected as much as we should be in public health. The rewards are just not there the way they should be. And with us being who we are, maybe we can still make a difference and make that change. But that was the first thing. Secondly, working to increase alignment between APHA units and recognizing that APHA couldn't do the work that it does without the units, and especially those state affiliates, right? They do some awesome work. But I would like to see the affiliates connecting more with the sections, and the sections connecting more with the caucuses, because caucuses, finally we are legit. We used to just be sitting on the sideline. We were just there. But now we have an MOU relationship with APHA, which is a good thing. But I would like to see us work better together. Those like-minded groups, I think we could do a better job at what we're trying to do if we come together and work together. And then finally, pushing for a deeper dive into unmasking the institutional, structural, and systemic racism. And until we are able to be honest, courageous, whatever it takes to tackle this, we're gonna have some issues in trying to move where we want to move as far as health outcomes, because these things exist. You might not experience them, but I can tell you I've experienced some of these things all my life. And it wasn't because I was sitting around doing ugly things. It just happens to some folk because systems are set up like that. And until we are able to have those conversations, and later in my talk, I'm gonna talk about how I want us to act on creating those spaces, right? So that we can talk about these things, because I know it's tough to talk about. People feel like you know, being accused of things. No, we need to talk about this ugly history that we have that hasn't gone away. So to talk about the institutional racism, which does exist, the structural racism and the systemic racism in some of the policies that keep us from doing what we do. So those are some of the things I want to work on, and building other relationships that I can work on these things and hopefully move it forward. Next slide, please. And I just wanted to celebrate you for a minute here, because I was part of some of the conversations on moving from health behavior and health education to health equity, to the name change. And I can remember some of the conversations and how passionate you were about that. And I just want to say congratulations for standing for what you believed in and for making that happen. So congratulations to you for that. Next slide, please. So I want to talk just a little bit about equity, because that's another thing that we have tripped over a lot. And even honestly, I wanted to use these slides, and I know that there are thousands of them and different ones say different things, but early on, we talked a lot about equality. We thought we wanted equality. You know, and that might be good down the road, but there's some things we need to do first, and we've started to realize that equity was one of those things. And these little boxes helped to explain that, and it made it clear to me how we needed to be thinking about equality and equity. And it's, you know, explained in different ways. So you've got these little boys on with the equality. They both have the same size boxes. I mean, all three do. In the next part, The one who doesn't need anything doesn't get anything. And that's hard to say to some folk, but it's a reality, right? He doesn't need it. The second young man only gets one, and the third gets two, which is great, right? And then folks started looking at that and thinking about, yeah, but how did he get up on that box, right? So there were other things at play. Next slide, please. And I think it's interesting where, on the second side, the right-hand side of the slide, where there's a ramp. Those look like steps to me. How the heck is he gonna ride the wheelchair up the steps, right? So even that's a problem. But just raising all of the possibilities and the things that could be wrong with how we think about that. But I think let me go to the next slide, please, and let me see if, yeah, this one goes a little bit further and talks about, giving everybody what they need, but also taking away the barriers. So, when we have those conversations and recognizing, trying to really understand what equity is and how it plays out in our work, it's good to have a good idea of what it means and how you can actually apply it so that it means something to you. Next slide, please. And I wanted to go back a little bit. Barbara and I talked about this a little bit last night, but how this all started for me. Others were already working in it, but connecting with the W.K. Kellogg Foundation and the Community-Based Public Health Initiative, I think it was. The initiative might not have fared as well as folk wanted it to, but we did okay because we took to heart the lessons that they brought, right? So thinking in terms of that collaborative approach that equitably involves all partners in research process and recognizes the unique strengths that each brings. CPR begins with a research topic of interest to the community and has the aim of combining knowledge with action to achieve social change. And we know that there are different iterations of that as well, and you don't always start with that thought from the community because some communities don't even know how to think like that. So sometimes you have to start with something else, getting people ready for that. But that program really helped to create the foundation that my whole public health journey has been based on. It helped me to understand how I could be a community partner, a respected community partner, a community partner with a voice, and a partner who could learn how, even though I don't use some of the words that you use, we might be saying the same thing. But another thing that really came out in those conversations is how important it is to define what you're talking about. You need to define those words because they mean different things to different people, and you create all of these meetings and you throw out all these words and everybody leaves, yay, we're gonna do this, and you leave on totally different pages because folk didn't understand what you were talking about. So I like having a smartphone because I like being able to Google when folk are talking. I can look a word up, and I even taught my grandkids, look, you don't have to be dumb. You have a smartphone. Even if you spell it almost right, most times it'll pop up, and you'll have some foundation, and you can be part of that conversation and not feel left out. But if folk don't know to do that, and I learned to do it from one of my sisters. I always noticed that when we were talking about stuff, she was on her phone. She was Googling stuff, but she always had something interesting to say. She could add something to the conversation. So we just have to, help people understand how we can do what we do better. And folk who don't know, let's share some insight, share some thinking with them so that they can be on the same page. And don't be feeling good because you're the only one with the information. That's not good. because you can take this journey alone, but it's going to be a lonely trip. If you share what you know with people and build relationships, it'll be easier to get where you're trying to go. Next slide, please. And so just to talk a little bit about community engagement, I mentioned these three, and for you they might be outdated, but I don't let stuff go that I like, so bear with me. I'm just saying. So the community-based participatory research piece is what I grew up on in the public health arena. And I like talking about the teach-back model because that's something Mrs. Deloney did all the time. And we would be in meetings, and I don't know if you guys ever saw this, but somebody would say something that I'm just gonna say it was just really dumb and offensive. And she would say, "Let me understand what you said to me. Could you share that with me again?" And that person would have nerve to say it again. And I have even seen her stand up, push her chair under the table, and go in to help them understand that's not what you need to be saying. But making folk, or making sure that you're on the same page with folks, saying what you think you heard, or asking folk to repeat what they said. I love that process. And the social ecological model, which I pulled from our Reach 2010 project, because we were dealing with infant mortality. And in many projects, you have an intervention working on one thing, and it always struck me that you get that thing perfect, but you got 10 other things that's causing a problem. What about them? How are you going to move forward if you only correct one thing? So with our Reach 2010 project, we had like 14 different interventions because we argued that all of those things were making a difference in our infant mortality in the city of Flint. And we did very well with that project. Next slide, please. And also thinking about effective collaboratives and partnerships. So these are some of the major partnerships that I have been part of, but it all flows back to the partnerships that we build, the academic partners that we had, the practice partners that we had, the community partners that were at the table. And let me just tell you, community partners don't always get along. At first, there were like 6 community partners at the table, and we didn't like each other. And we didn't talk, right? So there's no way that you can work if you can't even talk. So creating relationships and partnerships that really allow you to do the work is really important. So the Broom team was a group of folk in Flint, Michigan that was part of that initial initiative that Kellogg funded. The Reach 2010 project, the Michigan Prevention Research Center, I had the privilege of working with a couple of iterations of that program. The community-based organization Partners, which is a group of community-based organizations. It's an umbrella organization, really to help build the capacity of community-based organizations to help them move, grow, and thrive in the community. And the Community Ethics Review Board, which is a board that is able to review research that PIs are wanting to do in a community. So they would bring their research before our team. We would read it and talk about ethical issues that might be involved. And what we found is that oftentimes them coming before the Ethics Review Board allows them to do better at clearing their institutional review board because they've cleaned up all of the issues with the community component. And I still serve as the administrator of that. Next slide, please. And I talked a little bit about developing relationships, but employing evidence-based public health practices. So developing those relationship-oriented partnerships, showing up trustworthy. We all talk about creating trust. And in the community, we say it's important that you also, as academics, show up trustworthy. And the one piece we talked about, to making it clear, there are situations, there are times in some communities where stuff has happened. And sometimes the academic institution was not a good player. That stuff is, you might have gotten over it at the academic institution. The community has not. And if you haven't dealt with that, it's still there. For me, for you to show up trustworthy is to bring that back and say, we know this happened. This was way before our time. We know it happens, and we want to work beyond that. I think it's important to do that because otherwise it's just something tucked under the rug that folk are going to trip over forever and ever. You have to clean that up. And still building trust, practicing transparency. I still laugh how hard it is for academics to talk about the budget. That's funny to me. That's funny. And when we learned who Mr. Indirect was, that was quite a discussion, right? Wait, who is getting what? But you have to have those conversations. You really do. And I appreciate that now because, you know, you just, if it is what it is, you get over it or you just go away and you're not part of it, right? You learn to accept what is. And then showing respect. If you want to be respected, you have to show respect. Next slide, please. And this is just a slide I like to throw in to show what folk think about sometimes when they think about partnerships and all the different processes that might take place. But creating those partnerships is important, so you need to look at what you need to look at for your situation and build those strong partnerships. Next slide. This is my flagship slide, and I like to use it because in this instance, it's obvious that they're coming from a different perspective, right? But a lot of times in research, we have differing opinions. And just because you know you're right doesn't mean the other person is wrong. So what this does is ask you to just be willing to hear people out. Be willing to, even if you are just totally convinced that you're right, be willing to move a little bit so you can have that conversation and you might be able to help that person understand your perspective more. But don't just dig in and say, I know I'm right, and that's the end of it. Just know that the fact that you're right doesn't mean the other person is wrong, and that needs to be part of our thought process and our conversation. And so here, I want to talk about creating those empowering spaces, those conversations that we need to have to happen. So I don't think I've been talking long enough for you to be sleepy. But just in case, I'm going to ask you to perk up a little bit. And for just a moment, take a deep breath. Everybody join in. And allow yourselves to be present. Lean in, connect with, and dare to learn from each other. Right? In this space. Next slide, please. And if you're able to do that, I would say that you are actually in or you have created an E-zone. Those are zones that I'm advocating for, right? And I tell folk, the E could stand for Ella, if I wanted to think that way about myself, but I don't. It stands for empowerment zones. And I started thinking about that because oftentimes I hear folk talking about empowering the community. Stop saying that. That turns the community off. Create a situation where you both can be empowered, but not that you are throwing out empowerment dust, because that doesn't work. It doesn't work, right? So if you've created a space like that, and you will know because you're in a space where you're able to share and receive information. You're in a space where you not only show respect, but where you are respected. And you're in a space where you are able to recognize, accept, and feel confident enough employing individual and collective power. So I'm asking you to join me in creating these spaces wherever you go, wherever you work, whatever groups you bring together. Be that person that will help create a space to help pull other folk in rather than turning people off. I'm asking you to leave this presentation, this symposium, energized, engaged, and feeling like you are in a place to create these empowering spaces to help others. These are references, and I get teased about this, but this is my way of showing references, so I'm highlighting these organizations where you can go to their websites and learn more about the work that happens behind the scenes. So the American Public Health Association, the Community-Based Public Health Caucus, which is a caucus of APHA, which is what I was a part of that actually got me to APHA as well. The Great Lakes Public Health Coalition, the Michigan Public Health Association, and the Community-Based Organization Partners. These are all organizations doing great work, and you might be able to get some information from these websites. And I thank you.
Well, Daryl already let the cat out of the bag, but it is Ella's birthday today, and we are We're so appreciative of her taking time on her birthday to come and speak with us, and probably most of you don't know, but she's on her way to another symposium up in Flint. So, busy birthday. Thank you so much, Ella.
I was just going to say, we have a big family, you know, so this is my family here, and so in Flint, and I'll be honest and say, when I first accepted the invitation, I didn't know it was 2 symposiums. I was thinking it was just 1, but we were able to work it out, so it's good.
All right, thank you so much, Ella. Next, we're going to transition to our alumni panel. So if our panelists can make their way down, really fortunate to have a great set of folks come back, some that have been here in the area, some have moved all over the country, and then we're going to have Amy Schultz, who's going to provide the facilitation.
I'll come forward. All right. What happened to Rashid? Okay. So Rashid will be joining us momentarily. I am Amy Schultz. I'm on the faculty here. Is it on? I got to talk into it. On the faculty here in the department, and really so excited to be celebrating the shift in our name, which I do really think reflects the trajectory of this department for many years, and it's really exciting to me to see it actually official. It was quite a process, and I am so fortunate to be able to facilitate this panel of our amazing alumni, several of them. We have many others, but we have a great group in front of us today, and I got so excited. We've had a couple of prep calls, sort of just talking through how we wanted to use this time, and I know you guys are just in for a real treat with this panel. So we have in front of us Alana LeBron, who finished her PhD here in 2015. It seems like just a minute ago, but a few years ago, and she's now at UC Irvine. So we're going to be hearing from her. Ali Abazid, who is the founding director and chief public health officer for the Dearborn Department of Public Health. They're doing some amazing work with this, I'm still going to call it new, I know it's been 2.5 years, but this new Department of Public Health. So we're very fortunate that Ali is joining us. Brenda Henry, who you guys are going to, you can read her bio. She has had an amazing career in philanthropy, in city government, and now as a private consultant. There's probably some more things in there too that I didn't say, but we'll get to hear from her from the breadth of experience she has had. And last but not least, Rashid Njai, who's the Deputy Associate Director for Strategic Science at the Centers for Disease Control and Prevention. Some of you know Rashid. He's been doing some great work in Detroit with some members of the audience, and also was our graduation speaker a few years ago, and yeah, it was an amazing talk. So welcome, everybody. And I am going to kick us off by just asking each of you to say a few words about yourselves. Everybody, their bios are in the program for today. So what I've asked them to do is say stuff that's not in the bio, but just a brief introduction for each of you. So, Rashid, would you like to lead us off?
Hello. Yes. Hello, everyone. Rashid Njai. I think for me, I would just say, as was noted by some of the speakers earlier, for me, my journey has been about relationships. A lot of the people in this room were very important for those relationships, including Cleo Caldwell, Arlene Geronimus, actually Ella Greene-Moton and Ms. Deloney. They were my preceptors when I did my Ruth Health Scholar internship after my master's. And they were the ones who actually made me want to go on and get my PhD, because I came to get my MPH and I was going to go to medical school. And then I went to Flint and I was never the same. I said I wanted to stay in public health. And I think those relationships have carried me along the way. I feel like I remember talking to Mark Zimmerman around the Youth Violence Prevention Center and the work we were doing in Flint, and wanting to change systems and structures and speaking truth to power. And that made me want to go on after my PhD and go to the Epidemic Intelligence Service at CDC. And I've had the pleasure to be able to work with people like you who are first responders on responses. So I remember having the opportunity to talk to Regina Benjamin, the Surgeon General at the time, and talking about doing work on the front lines. I remember being in Ebola in Sierra Leone, and those experiences that made me want to continue to change systems, continue to change structures, and want to really work on the upstream factors. And I think those are the things that have propelled me. And it's been a challenge at times, sitting in the federal government, because I'm muted at times. And the ways I've been able to navigate that, as I started a nonprofit, I do a lot of things outside of my title. I'm out of uniform today. I'm usually in uniform. But one of the things I think that remains with me is keeping that relationship with myself, my true core values. When I saw Ms. Greene-Moton last night, she said, "You know what I always remember you by? I remember you by your hair." She said, "Where's your hair?" And I said, "Give me 4 years and I'm gonna grow my locks back." So for people who knew me back when, yeah, I had my locks, and that was—
Down to here.
Yes, that was one of my calling cards. And my locks are still here. They're still here. My dashiki is still here. I remember the first time I presented at APHA, and that's what I had on. And that's, even though I'm in uniform, that's really my uniform, my internal uniform, and that's how I show up for people every day. And I feel like those relationships that we carry are very important, and that's what's driven me to continue to serve and be in service, even today in the CDC's Office of Health Equity, and I think that's where I'll end it. I love the transformation, the title transformation, because this is a critical time in our country. Politically, there is a political will, but there's also political pendulum that is swinging. So I think it's very important, I think it's very timely that now in this moment, we're making this transformation very intentionally and very purposeful. And I'm honored to be here today with the speakers.
Thank you, Rashid. Alana, would you like to? We'll just go down.
Okay. So I'll share a little bit about how I came to public health and academic public health as well. So my own lived experiences with health inequities taught me at a really young age about the profound impact on structural factors. So I knew that I was interested in public health. And it was in my training that I came to see that data could be really powerful in terms of really challenging dominant narratives that can be harmful for our understanding of health inequities and the contributions of structural factors, and in turn shifting towards thinking about solutions. My first job out of college was on a public health research project, and I learned a lot about what I didn't want from public health research. So in that job, I called it the blood, dust, and spit study. It has definitely impacted our understanding of the contributions of air pollution and maternal stress on children's respiratory health. And there were many things about the research process that were really problematic for me in thinking about how do we go about working towards health equity. So in my role in that project, I connected with a lot of Central American immigrant moms to understand their own lived experiences. And it was a longitudinal project, and so I got to see them over multiple points in time when their kids were young. It was like every 3 or 4 months. And I had the privilege of really building relationships with them, right? Of like holding their kids, being in their homes, eating food with them. And as I got to know their stories, I also had opportunities to accompany them sometimes. And these would be small acts of accompaniment, like translating a document from the school or going with someone to a police station. And as I got to know them, I realized like the study findings like weren't coming back to them, and there was also no real impact of the work. So the projects were very much sort of extractive of let's learn about folks' exposures to the harms, right? And let's capture the impacts on our biological systems. But community wasn't showing up and guiding the research process. Literally the findings of these like dust samples and blood samples were not coming back to families. And there wasn't any linkage in any way to disseminating the findings for impact and advocacy. And in that work, I also learned that from the researcher's perspective, while relationships are key to better understanding these issues, accompaniment was not welcome, right? And that was really problematic to me because the message was, we are studying health inequities. Any sort of deeper relationship or accompaniment is intervening on that system that we're trying to study. And so I felt very convicted that any potential impacts of that way of doing research were going to be blunted because they weren't rooted in community. And so I was really curious about models that practiced the sort of transformative work of relationship building, of community guiding research questions and dissemination. And that's what brought me here to Michigan, which I think a theme from our conversation so far today has really been just what a unicorn Michigan public health is in terms of helping us to really critically reflect on where community shows up in our research processes and how to center community in health equity related work. So that's sort of what brought me here to Michigan, and I learned so much, both in the classroom, but also outside of the classroom. So I worked a lot with the Healthy Environments Partnership, with Amy and Barbara, and I learned so much being in that space, really understanding some of the inner workings of community-based participatory research, and also learning from the community-based organizations that had leadership roles there to understand how the research questions were connecting with things that were unfolding in real time, in real life, in Detroit, as well as what does it look like to share power and to really think about translating the research to inform action. And so that's set me on my path as an academic public health person focused on understanding how does structural racism make us sick, and also what are community-driven solutions, right, to intervening on structural racism and promoting health equity. And so in my projects, a lot of my work focuses on understanding what are community-driven priorities and questions, and then figuring out how, if at all, can we be accomplices as researchers in that work, and then thinking creatively about what that research can look like and advocacy as well.
I've prepped Francis Collins and Anthony Fauci ahead of hearings on the Hill for appropriations meetings. I've been in rooms with cabinet secretaries and presented before them. I've been in refugee camps in Lebanon where I've heard missiles go off in northern Lebanon from ISIS. But for some reason, being back in this classroom with former professors is making me a lot more nervous than any of those things. And so be kind. Those ideas of waking up with a nightmare like you're about to be graded or you have a test, they're very much front and center right now. So I bring that into the conversation this morning. I had dinner with Barbara Israel, Amy Schultz, Miss Ella Greene-Moton, Daryl Hudson, who, by the way, is a dope-ass chair for this department. And I am so excited for his time here. I say that because I was in grad school just a few short years ago, and I was reading these people, you know, and I was thinking about what it might look like for, you know, this kid, this child of refugees to have an opportunity to exercise this thing called public health. I didn't know what the hell public health was until I was 21. I think I always knew that I loved public health, even when I didn't have the language. But I was that, you know, Arab kid who grew up in the ethnic enclave community where you go become a doctor or an engineer or you're screwed, you're a failure. I think I'm still a failure to my mom. She loves me and she's so proud of the work that I do, but I'm not an MD, so I think that matters. But as I'm thinking about, you know, how I got to where I got to, it's the people. And you know, that guy right there, Gary Harper, who is damn hard to get a hold of, by the way. I'm sure everyone in this room knows that. That guy is one of those people that fundamentally changed my life. I had, you know, I was a terrible student. I gotta fully confess, a terrible student. I loved learning. I loved, you know, education. But I really felt for the longest time what Ta-Nehisi Coates describes the classroom as a prison of other people's ideas. I felt that. I will fully confess. I lied my ass off to professors to get out of assignments and exams. I know Gary knows that. We look back forgivingly, though, Gary. And you know, I applied to medical school, was on that track, took the MCAT, studied neuroscience, always knew my heart wasn't in it. But while I was waiting to hear back from medical schools, I got an opportunity to join the CDC with a fellowship. And I had also gotten accepted here for my MPH. And I don't know how we got connected, but someone connected Gary and we got on the phone, and we started talking like we've known each other forever. And Gary said very explicitly, Ali, come here, just come to Michigan, you know, and after you do this thing, you'll be able to do the CDC and whatever the hell you want to do, but come here, and I did, and my life has changed because of that guy right there, who I love, by the way, and I know so many of you do too. Yeah. And it was other people, like, you know, Daryl mentioned Woody Neighbors and brought back so many memories. I was, again, a terrible student, and I was a terrible student not because you want to be a terrible student. You're, you know, a kid who's struggling with depression and anxiety and all the other things that you go through. And I remember Woody was the first professor I've ever had in my life who, rather than, you know, dismiss or wholesale just ignore what people might be going through, he approached me and he said, "What's going on, kid? You know, let's talk about this." I think for a man to do that, let alone a black man, to approach you and say, "What's up? You know, no punishment, no harm, let's just talk." That also changed my life. And so where I ended up is completely the result of the people in my life. And that's a central theme to my work in public health, because public health is fundamentally about people. I think we sometimes forget that, and this is not a critique, although critiques are fine too, although maybe it is a critique. In the academy, we sometimes forget that our work is fundamentally about people. And so, finished grad school, was selected to join the federal government on a fellowship, Gary, you were right, and I ended up at the NIH and spent the last 5 years, or between 2017 and 2022, in the federal government, rotating around the federal government, health and human services, working on cancer control and prevention, working on refugee rights, working on a whole range of issues. I loved my job in the federal government. I loved it. The scope, being able to work on things in rural Appalachia on one day, and then in Oklahoma on another day, in a tribal community in the Dakotas another day, I loved that. When my hometown of Dearborn elected a new mayor, people like to often call Mayor Hammoud the first Arab American mayor, but I don't care about those identities myself. I care more that he was Dearborn's first ever public health mayor, because he graduated from this place too. And he wanted to do something radical, which is start a brand new health department. And I laughed at him and said, ha ha, no thanks. And he was persistent. And I don't know what it is about Amtrak's, but I was on an Amtrak one day from DC to New York. I was actually going to catch the launch of the 1619 project. It was the first event post-pandemic in New York at the Apollo Theater, and Nicole Hannah-Jones and Ta-Nehisi Coates were there. And he caught me while I was in the Amtrak. Amtraks are really romantic. You ever want to make a decision in your life, you take an Amtrak. And that's when I pledged to him to think about it. 4 months later, I took the job, and for the last 2.5 years, I've been in Dearborn, because I think that the pandemic showed me what you all know already. Public health has failed in many ways over the last 4 decades. Not necessarily because of our own volition, but it's failed because we're a victim of our own success. I think the time for public health to be humble and quiet about itself is long past. We gotta talk about ourselves. You know, we're not McKinsey or E&Y or management consultant firms who tell the stories about themselves really well. We gotta tell the work of our work. And so for the last 2.5 years in Dearborn, we've been tackling really important work, I think, really exciting work, I think, and we're not shy about telling the story about the work that we do.
I just don't know how I follow that. Good morning, everyone. It's such a pleasure for me to be here with you all today and just look out in the audience and see so many friendly faces. It is so hard for me to wrap my brain around the fact that this fall makes 25 years since I started my Michigan journey. 25 years ago. And speaking of pivots, Michigan was not my first choice, okay? I had, prior to Michigan, like 4 years prior to starting here, I had done a summer internship in Atlanta. It was called the Public Health Summers Fellows Program as I was wrapping up my undergrad. And the partnership was with Morehouse School of Medicine, Emory University, and the CDC. And so I was placed in Morehouse School of Medicine, and I just fell in love with Atlanta. And so my goal was to go to Emory, do my MPH there. And we've invoked his name, and so I'm gonna invoke it again. And then all of a sudden, I applied to multiple schools. You know, I'm gonna be responsible. Michigan was one of them. And I had already sent my deposit to Emory University when all of a sudden I get a letter from a certain Dr. Woody Neighbors saying, hey, not only are you accepted, but we are willing to give you some funding. And so I, reconsidered, and then the rest is history. And it's one of the best pivots I could have ever done. My public health journey started before Michigan. I was a public health major as undergrad. And aside from knowing that I wanted to leave my corner of the world better, I didn't necessarily make up my mind in terms of how I wanted to do that. But when I look at the theme and the thread of the different spaces and places that I've been, because as Amy said, I have been in different spaces, city government, philanthropy, academia, and nonprofits. The only sector I have not worked in is corporate. I'm sure at some point in time, now that I'm consulting, corporate will come in there somewhere. But the theme and thread has been that I've always worked to address systemic issues, mostly structural racism, but when we think about broader systems of inequity, it's any and all systems of oppression. I grew up in the Boogie Down Bronx, and as Alana said, you know, lived with a lot of the issues that we learn about and study and understand, but actually it was in Michigan, right, where I learned certain things about my own home borough, right? Certain narratives about the Bronx that I hadn't learned there growing up. It was in Arlene Geronimus's health and poverty class that I learned, oh, it wasn't just people in the South Bronx that didn't care about their buildings that were burning their buildings down. It was systemic structures, decisions that the city made to close certain firehouses and greedy landlords who wanted to collect insurance, right? And so anyway, it was in Michigan where I got all of the tools and the thinking around how systems and structures shape and mold behaviors. So it's not just people deciding that they don't want to be healthy anymore and deciding to engage in choices and decisions that negatively impact their health, but it's the structures, right? The structures and the conditions that roll down, right? So, we'll wait until the rest of the panel, but I will say that in the latest iteration of my journey, it touches upon a lot what Ella highlighted, and then I would say also what Dara highlighted, which is, you know, I'm building now for what does the future of liberation look like, right? What does the role that healing play? The last 2 years of my own personal journey has been my own personal healing journey, because as I've been doing all this work to address systemic oppression, somehow I lost track of the fact that I'm also somebody who's living within these systems, and as somebody who's committed to truth-telling, have experienced harm and violence from these systems for my truth-telling. So I had to do a lot of internal healing work to make sure that I am not a system of oppression, that I am not a conduit of oppression. And so that's been my work, and thinking about the role of love and how do we root in love as we do this work. So it's a pleasure to be here. I'm so excited to be back and can't wait for the conversation.
Yeah, thank you, Brenda. Thank you, everybody. So as we had a couple conversations and we're preparing for this panel, one of the themes that came up in those conversations and that has already come up today is the theme of relationships. And one of the things we wanted to give space to talk a little bit about is each of you holds very different positionalities from which you do your work. Several of you have held very different positionalities over the course of your career. And we wanted to just give you a chance to talk a little bit about how those positionalities have informed your work towards social justice and ultimately health equity. And as part of that, to talk about how you leverage those positionalities, both personal and professional, in order to promote change towards health equity. And we've really decided that we're going to structure this as a conversation amongst the panelists. So I invite you guys to talk amongst yourself about that question. Okay.
So remind me what you said, so positionalities and how we've
And your
leveraged them.
relationships, how you leverage those relationships.
So for me, it's really about, and now that I went back and got my social work degree, so I'm always trying to listen to myself and be present with myself. For me, it's about really trying to leverage relationships to lift up voices. So for me, early on, when I got to the CDC, I remember I was like, I know all this stuff. I know the socio-ecological model. And I would get to a meeting, and people would be like, we don't want to hear about that. That's not of interest to us, right? We're worried about a budget. We're worried about different priorities. And so I was like, okay, this is going to take some time. So I realized that time was of the essence. And I realized I could work a lot faster if I enrolled people and had relationships with people who were making decisions and were in rooms that I wasn't in. So a lot of the positionalities that I was able to leverage was at lunchtime and having conversations and talking to people who were in those meetings that I couldn't be in, and talking to them like in the ways that we're talking about the socio-ecological model, talking about structural racism, talking about things that I wasn't able to say in the meetings when I first got to the CDC. I was having those meetings with directors and having those lunch conversations with CDC leaders, and was able to kind of leverage my understanding and trying to translate that understanding to people who were in those meetings and had those opportunities. And I feel like over time, as I've been able to kind of work my way up, so to speak, I've been able to change that conversation from me speaking to those people who are making decisions, to me talking to community and lifting up those voices in those meetings. So I'm now in those rooms, in those meetings where decisions are being made, and I'm able to leverage my position. And I'm also able to cite people like Dr. Hudson, like Dr. Geronimus, and I think that's, because a lot of times in the federal government, people are like, what's the evidence? We have no proof. We have no proof. And so I really leverage my positionality and my relationship with people in public health and academics, people who are doing the work. Not to say I'm not doing the work, but I don't often have the same ability to broadcast community voices and show the evidence and the connection. So I would say that's how I would start. That's how I leverage my positionality, is trying to kind of lift up that voice and bring those relationships into those rooms where the decisions are happening.
I want to riff off the translation piece, Rashi, that you were highlighting, because I found in the different spaces that I've been in, the translation is so critically important, right? One of the pieces Ella mentioned in her talk in terms of language, like, sometimes you have language issues between people who sit in different positions, but I have found that you have 4 people who are same position, same role, and they don't necessarily align on how a certain word is being used. And so the translation piece I have found being a critical importance for me is like, okay, when we say this thing, can you explain to me what you mean? Because I know what I mean, so that we can make sure that we're on the same page. But in my position, I've worked in philanthropy for over a decade. And, for those who are not familiar with that sector, philanthropy was built on accumulated wealth, on all of the systemic issues of oppression that we can talk about, right? However, they are very historically white dominant spaces that engage in ways that can be harmful, and engage in ways in which we're trying to dismantle, right? And so as, a Black Latina, with the PhD, right, I came into that space naive, thinking that I had gotten this credential that technically makes me on equal playing field as everybody else. And I quickly learned, no, that's not the case, right? So then I had to figure out, okay, how do I position myself in a way where I can still move the money to the issues and the people that I know will do the best with it, while I minimize harm, right? And do so in a way that is still rooted in my authenticity and in my integrity, and in a way that doesn't engage in transaction, right? Because that's another element, right? Where, and Ella was highlighting it, for you to have authentic, trusting relationships, people need to understand that you see each other on equal playing field. It's not that you're here and I'm here because you can provide me something, but we can provide each other something. And so I feel like I've tried, right? Other people would have to tell you, but I've tried to show up in a way where folks understand what the basis of our engagement is, so that I can minimize as much as possible the engagement coming off as it being transactional nature. And let me be clear, if it is a transactional relationship, being clear that it's a transactional relationship, right? Because not all engagements need to necessarily go beyond the transaction, but being clear that that's what's needed. But I've always tried to figure out, how do I leverage the position that I'm in, the power that I have, to create space and openings for folks that I know, right, are not in those rooms and have those power. But the translation piece is key, because you have to figure out, okay, what's going to speak to you, right? If you're the decision maker, I need to figure out how to put this in terms that speak to you. And that was hard, because I'm a person, but like, why can't I just say it the way I want to say it? Like, why do we have, you know? And then I just had to get over that and figure out, okay, what's the goal? If the goal is to move it, then let's figure out what it takes to move it.
I think for me, the dichotomy of difference is something that I just grew up knowing, just knowing how I was different than other people. I think all kids are actually great at this, you know. They're able to recognize differences, you know, like, mommy, why does that person look different? Why is that person sitting in a wheelchair? Why is that person's skin color darker? Why is that person's clothes? And the list goes on and on. And so I think for me, my mind always wandered in terms of how I was and we were different than other people. It was very clear at an early age that we spoke a different language, literally. It was very clear that we had less money. It was very clear that we were amongst many people that looked like us in Dearborn, but when you stepped out of Dearborn, you were suddenly around different people. You knew when you were around black people, you knew when you were around white people, you knew when you were around rich people. Those are things that always sort of just stuck with me. And I think it was until way later on that I sort of developed this new language around public health and what I wanted to do with public health, that I recognized my positions in society matter, but also that they're not static, that they're constantly changing. And for me, I really root my work in public health because, you know, as Rashid knows, the federal government is a place where there's a way things are done, and there's a reason why things are done that way. I think one of the biggest misconceptions in American society is just what American government is and what it does, and I think there are reasons for that. I think bad faith actors have decimated the perception of government for, you know, their ill-rotten sort of aims. But the federal government is full of, in my view, some of the smartest people on earth, doing the things that they're working on, whether that they're at the EPA or CDC or NIH. I'm not willing to go there on the Department of Defense, but you know. But the federal government is full of some of the smartest people. And I, as someone who considered myself highly informed and knew what the government was going in, I was shocked by that. And you go through that and you sort of work through that, and what I came out of it recognizing was there's a reason why we do the things that we do. But for me, I was always, you know, sitting at the NCI, and we were putting out new grants for, you know, cancer control in West Virginia or Indiana or Kentucky, colorectal cancer screenings, and I would always just come back to, y'all realize that, like, if we had universal health care, that a lot of these issues would be solved. And that wasn't disruptive. It was actually healthy, and there was a room for that conversation. And when I ultimately left the federal government and we endeavored on starting a brand new health department, I told the mayor he should be careful what he's signing up for with me, because that's when I got to that place that Brenda, I think, is talking about in terms of translation and being able to sort of be authentic. I talked about very openly on day one of the job, our fundamental work here at the Dearborn Department of Public Health is to uproot the orchards of white supremacy that are growing across the country. And we are going to explicitly and unapologetically center people closest to the pain. That means reckoning with our history in Dearborn as a city with the largest suburban border with the city of Detroit in the ways that we perpetuated anti-black racism. We had a mayor so vile and violent this past Tuesday at City Council, we finally removed his name on all city buildings, by the way. Orville Hubbard, who served from the, a vile, vicious white supremacist who was an open segregationist from the 40s to the 70s, who was so violent that he would meet regularly with George Wallace, that George Wallace. And we had, up until 2006, on our police cars, a slogan, "Keep Dearborn Clean." That wasn't pick up the trash, that was keep black people out of Dearborn. And so recognizing the roles in which structural forces and racism play into health like, shame on us if we're in public health and we're starting a brand new health department and we're not gonna start there. And so we started there. And I'm the sucker that took the job with no staff and no budget, by the way. So not only was I making enemies left and right, but I also had no resources, and the city council hated what we were doing. But we do it. And I always say, like, if I didn't want to do the work, I would have gone and become a cop, you know? Like, if I wanted to just police people's behaviors, but you do the hard work, you do the thankless work, you do the impossible work sometimes, and I think that's what I'm most excited about with all the things that we're all sort of doing here with the name change today is I think we're finally disabusing ourselves of the notion that public health shouldn't go there. We should go there. We should have gone there. And I'm really excited that we're going to continue to go there. Yeah, so let's keep going there.
And I just have to just jump in because I just want to say that Ali does go there. And if any of you have been following the newspaper articles about the actions that they have taken with their new public health department, they are pretty radical and amazing. And he's really demonstrated what public health can and should be doing. So.
Yeah, so I want to approach this question from the perspective of like being in academic public health. So for me, I grew up in a small town at the time outside of San Antonio, and my family was the only Puerto Rican family in that community, where there was very much this white Mexican-American binary. And so race was always the salient concept for me as a kid. And so I also grew up with this sense of like a minority status and a misfit sort of like identity. And accordingly, my educational journey and career trajectories have taken me to places that I didn't grow up in and where like my broader sort of people and family were not. And so I've had to reflect a lot on positionality vis-a-vis also identity. And in my own position as a faculty member, I certainly hold my identity as being in the margins within academia, right? Like first Latina person in public health in my department, but also like attached to a powerful research university, right? And many times our universities are major employers for our region. They often contribute to gentrification, right? Processes in our communities, those indirect costs, right? Exact major inequities. And then there's things that we get right sometimes in our training and research and things that we get really wrong. And so there are these legacies of harm as well. And so all of that comes with me in my work. And as I settled into Orange County, very new to the area, starting over like yet again in my journey, very much the work for me was about building relationships. And this looked for me like just being in a lot of community spaces, figuring out like where is the grassroots like work and where are those conversations happening. And as I was starting to build relationships over time, we spent a bit of time at like literal retreats, like leaving the area and just spending a weekend together, getting to know each other, and sitting with this really just broad question of like, what, if anything, could we do together? Or what might we envision in terms of our approach to this issue that we're starting to coalesce around? And that's been really, I think, fruitful in our work. It's led me down a path of focusing on resident-driven concerns about lead in the city of Santana. And with respect to thinking about positionalities and relationships with various institutions, I definitely reflect on my relationships with community partners. And I certainly acknowledge that there are major differences, right, in thinking about my educational trajectory, my employer, the flexibility that's afforded to me in my position. But there are also many sort of like unifying experiences too. And so it's through the relationship building that we've really come to see that we have these shared experiences of migration, right? Either in our individual experiences or our family histories, of calling multiple places home, of having our hearts in many places. And so I think finding those points of unity are really important, as well as acknowledging our different positionalities. And with respect to sort of wearing my academic hat in a lot of my work, it's been really interesting to be in community-based spaces where we're really trying to center community power and have needed to engage governmental officials in various moments of time. And what sort of my positionality has looked like has sometimes been to be in the space and to just echo, you know, what someone had just said, right? Like, well, this comes back to what Senor Rea just said, you know, just echoing that for our Department of Public Health, for example, or consolidating, you know, a discussion that we've had into a formal memo, you know, that we might send to our health department, but putting it on our university letterhead while also acknowledging community partners. I'm doing some work right now where we're really coalition building at the county level and trying to really work on some of those structural forces and thinking about the county budget. And it's been interesting to be in that space from the perspective of an academic partner who's also a community member in some senses, but to be invited to show up with my academic hat, especially as we're thinking now about like, what does governance look like? And sitting with really important questions like, well, I'm representing a university, right? And so maybe I don't have a decision-making role, right? And it's also been helpful to know when I need to be present in some of our coalitional work as well.
Great, thanks everybody for those responses. And one of the things I just want to lift up about this conversation is that we often talk about relationships with community as if community is something outside of our institutions. But I also just want to point out that several people here also talked about building community for change within the institutions that they sit within, and to recognize that those kind of relationships are also part of thinking strategically about how do we mobilize change. I'm going to warn everybody here before I ask the next question that we were very intentional about leaving a part of our time for a conversation with you all. So I'm going to ask the final question of the panel, and as they talk about that, please be thinking about the conversations you would like to have with them. We'll have about 15 minutes, I think, at the end of our time to do that. Okay, so the last thing that we wanted to invite the panel to think with us a little bit about is, you know, we're at, and a couple of you have already mentioned this, we are at a pivotal historical moment. And we wanted to invite you all to reflect a little bit about what you see as the greatest opportunities of this moment for moving towards more equitable health outcomes, either within the US or globally. Feel free to also touch on challenges, but we would really like this conversation to think about opportunities.
I'll go first. I think we have a tremendous opportunity to leverage our positions. I think when I was seeing Brenda always reminds me of the critical mass that we had at U of M in 2001, and not just in the School of Public Health, it was across the entire university. And just soaking all that in at that time, and now sitting now when I look back and I'm able to look at Facebook and LinkedIn, and I'm like, I know these people. Like, I know this person who's doing a keynote here, and who's the president of this, and who's the chair of a department. I know those people. I can literally text them. I can text them, and I have to text them and say, hey, what the hell is going on? What's going on in Michigan? What's going on in California? And leverage that to do something now. Because otherwise, it takes a lot of time. Like Ali said, like sitting in the federal government, it's nauseating. We'll have meetings about meetings and conversations, and for something to happen, it will take 4 years, literally. I watch things take that long. Whereas if I get on the phone, if I send a text, if I send an email, I can change things now. And I will say we have a tremendous opportunity right now. I know people are worried about the future. People are thinking about the past. But right now, present, like we have an opportunity to make tremendous change and movement and create things outside of the current structures and systems. I know we were talking about that. Like, I know Brenda lives in that space of being able to create and just be open to creating solutions that we talked about in class, that we talk about in classes, in hallways, at dinner. Like, we can create those now, and I think we have to be unbound and not, you know, put ourselves in those boxes. I think we really have to accept that challenge to transform, to change names, to change the narrative, to translate, and to bring those stories, our lived experience, to the table, and do it now. Because I think that's what I think about. I was talking this morning, and I was like, I wonder what my great-grandparents would think about what I'm doing right now, like in this moment. And I think that's where we have to be right now, is think about how would our ancestors think about what we're doing right now and what we have an opportunity to do, because we have a tremendous opportunity. I don't care who's in office, I don't care anything that's going on, we have the ability to make that change right now, and I would say I think we have to take it. We have to take it and not be worried about anything else. And that's how I would start this conversation.
So I have a few thoughts on this. The first is I do think that we are increasingly experiencing a lot of volatility and crises. I think about the students in my classes and just how every year it seems like there's a major disruption, and that was not my own learning environment. Daryl, I loved your reading list, like, by the way. And I think about this question, and Adrienne Marie Brown comes to mind in her work around like small interactions. And we know that the conditions that produced health inequities are racism, capitalism, like all the isms. And the work to reach towards health justice is the antithesis of that, right? And so it involves so much learning and unlearning, and I think relationships are really critical to that. And in this moment, it's really helpful to remember the power of those small interactions, right? Of like practicing justice and liberation for ourselves, which I think Brenda connects with your theme of like healing, right? And remembering ourselves as recognizing our humanity in these processes. And then also thinking about our relationships with each other and practicing that more just world that we want to see and be in. And I think this also takes significant advocacy and effort. And as a broader field, I think we really need to spend some time thinking about what does that look like to build our capacity to engage in sharper advocacy and effort, and to do it in a way that models, right, this world that we want to be living in.
I'm so glad that you mentioned, Alana, Adrienne Marie Brown, because I feel like I inhaled all of her work when the pandemic started. And for those who are not familiar with her work, what Alana is highlighting is within her book, Emergent Strategy, but even if you don't get her book, she's done podcasts, and it's amazing. But it's this notion of how we as individuals embody either liberation or we embody oppression. And that in any given moment, we can make a decision or take an action that moves us in liberation or moves us in oppression. I'm doing the binary, but it's not fully binary, but just as a notion. And as I was thinking my response to the song, to this song, it is a song, but to this question, I think of a quote that I have framed right above my desk in my office, which is by Thich Nhat Hanh, which says, the quote is, "Peace within, peace in the world," right? And so, you know, this moment is really hard, and I just want to name that. You know, Ella mentioned the importance of naming the thing. It is really, really hard, right? We have our fellow humans suffering at levels that are just really challenging, and we are watching this suffering unfold right in front of our eyes. Our brains were not wired, right, to take all of this suffering in. And so I just want to name, right, that this is hard. And I also want to name the silver lining of that it's hard because as humans, we connect to somebody else's humanity. And I think that's a beautiful thing, right? We're struggling because we should be struggling, right? And then how do we get to the other side of that? And so, you know, it can get very overwhelming, right, to think about, well, how am I going to change that dynamic? What can I do, right? But as Alana said, I feel like, you know, the way that I get back to my hope is think about, okay, well, what is it that I can do within my interactions, within my relationships, with the people that I engage with on a day in, day out basis to make sure that I am creating a connection rooted in love, right? And sometimes that love is not always, you know, kind of happy-go-lucky. Sometimes that love is fierce and it's challenging and it's anchored in principled struggle, but it's anchored in a struggle that will get us to move forward. And so that is my kind of response to the moment, is just thinking through how, and as you know, Rashid said, not in some distant future, but how can I now, in this moment, show up and embody the type of future that I want to see that is rooted in liberation. So that's what I think about in this moment.
I'm not too optimistic about the future. And you know, that's not a message of despair. I think despair is useless. There's no solidarity in despair. There's no point despairing. And this isn't one of those, oh, like, let's see the battle for what it is so that way we can prepare and confront it. But I'm not. And I think that's important to say out loud, is you don't always feel hopeful. You don't always feel optimistic. How can we? I mean, just look around us. And the obvious stuff, and also look at our Supreme Court day by day, eviscerating the norms and traditions and customs and foundations of an already broken system and making it even more broken. We all know the obvious stuff, Roe v. Wade, and the way that they're gutting the ETA. I'm Arab, I'm always late, so ETA is on my mind. It's another thing that we have in common with black people. EPA, gutting the EPA. Chevron, you know, basically eliminating the doctrine and giving judges, who are partisan hacks, by the way, both ways, more power. And so I think it's important to name that too. And I say that because I think that's yet another reason why public health should go there, and go there where we haven't been before, because the challenges before us are really supreme and significant. I love the book recommendations and the reading recommendations. Mine own are usually fiction. I always tell my students, read more fiction. I've learned more about the human condition from fiction than I ever have from any self-help book or nonfiction book. I think every book is a self-help book. But whether it's, you know, Mohsen Hamid and Exit West talking about migration only the way a novelist can, or the way Zadie Smith writes in White Teeth about the globalization and people coming together, or, you know, whether it's Layla Al-Alami writing and the other Americans about what it means to come from another place and being from multiple places. And for me personally, I've always relied on and leaned on black scholarship in particular. And I think there's something there besides just it's excellent work. I think it's black people in America understand the consequences and the costs of the myths and metaphors that America tells about itself, or the price of America telling the story about how good we are. And I think it starts with telling the truth. As Du Bois said, the truth, insofar as the truth is ascertainable. And so for me, it always starts with truth-telling. And when I think about the truth and when I think about us being here today, this is a momentous thing. I know in academia, we typically make small things big, and we love to be stuffy and fluffy with a lot of, this is a big deal though. Changing the name to include health equity is a big effing deal. And I say that because I'm someone who recognizes and appreciates that your name is the only thing that you own in its entirety. And my sincere hope is that we tell the truth about what health equity looks like here, what it looks like elsewhere. I hope that we own our name in entirety for Black kids in Flint who have yet to get any justice as a result of being poisoned by their government. I hope that we own our name in entirety for folks who are incarcerated, because we recognize that making a mistake shouldn't condemn you, and also that we believe in redemption because we're public health people and everyone's redeemable. I hope we own our name in its entirety for abolishing once and for all the primitive medieval practice of the death penalty, which we know has nothing to do with innocence or guilt and is just yet another sort of part of the American machinery of serially killing Black people. I hope we own our name in entirety for the Palestinian kids in Gaza, because we recognize too that you can't live a healthy and dignified life under occupation. That's just not possible. And so I hope we own our name in its entirety for all the things that we all hold dear, because we're public health people and we care about people. And I hope we center that first, second, and last.
Well, wow. Join me, please, in one more round of applause to thank this amazing panel. I'm so inspired by the work that this group of people are doing, and many of our other alum across the country who are thinking deeply and working in profound ways to move forward towards health equity. So thank you guys for making time to come and share your work with us, your insights, and the work that you do in the world is so valuable. Thank you. We have about 15 minutes for you guys to talk to these guys. So I gave you some forewarning about that, and James, that I see you're ready to jump right in. Okay. Oh, let me actually.
I guess I just have a question for Ali. You said you worked in northern Lebanon, correct? And I worked in Lebanon too this summer, and my question for you is, how can you talk to us more about how your work over there reflected on your work here at, whether it is in Dearborn or any other public health work that you had?
I did my public health internship in Lebanon working with Palestinian and Syrian refugees, primarily mothers who had just given birth. This was in 2016. And, you know, there was my family's Syrian, and so there was an episode where we were in one of the sort of the worst condition refugee camps, internal displacement camps, I think they're still called. And they were in the Bekaa Valley, and so you're imagining two mountain ranges, and this was the summertime, so we didn't feel it, but in the winter it turns into like a wind tunnel, and you have these paper tents that refugees were living in. And there was a Syrian kid, 17 years old, and he approached me, and he had a bunch of Lebanese wristbands on his wrist. And I said, like, what are you doing? Like, what's this about? You know, you're Syrian, you have a bunch of Lebanese wristbands, and I love to always tease my Lebanese friends. And so I started teasing him, and he said, well, I do this because whenever I try to go to the south, or I try to, you know, sneak into Syria, or sneak into another country, I'm hoping that they'll see the wristbands and just assume that I'm Lebanese and let me pass. And then he asked me a question. He said, are you American? I said, yeah. He said, do you have a passport? I said, yeah, I do. And he just did this thing where he just looked off into the distance and said, you know, what it must be to be you, what it must feel like to be you. And I think about that constantly because my time in Lebanon just kind of honed in on the core essential feature that public health is about people, but it's also about place, that the kid in Detroit might have more in common with the refugee kid in Lebanon than he does with the kid in Bloomfield Hills or in Ann Arbor. I drove from Detroit this morning. I traveled 6 years in life expectancy. And those, y'all are laughing, but that I did. That's the reality. And so I think the biggest thing that came out of my time there was place is really essential to how we think about public health.
Thank you. Other questions, comments?
I talk to a lot of kids between the ages of 16 and 24, partially because my children fall in that, but other interests I have. And the thing, I feel like most of them have partially given up on having a family. They don't think they'll ever achieve the economic stability that their parents do. They see all these conflict zones in Sudan and Palestine and Ukraine and so many other places around the world, and they just can't even make sense, even the political science majors, about what the world is doing. And of course, their number one thing is, why would we bring population into the world with climate change? It always rises to the top. And it so much does in so many conflict zones too. So what would you say to these 16 to 24-year-olds who are supposed to be finding hope some way and somehow to grow up and contribute to the world? And they want to, but they can't reconcile the world that is.
I'm not going first. Don't look at me.
So just in terms of thinking of this question, when he passed away, my husband's an artist, and there's some people in this room who have, been able to see his incredible artwork. But when Nelson Mandela died, he did just a small sketch of him, and with a quote that it always seems impossible until it's done, right? And so, I feel like, and again, let's recognize we are inundated with images and information at levels in which we've never been previously in history. However, there are other moments in history where things happened that no one for generations or centuries prior would imagine would happen, right? And so I think that's what I lean on, right, is that, because what's the other choice, right? Like, regardless of who is in office come January, the work still needs to happen. It's just a different strategy, but it's not like the job doesn't still need to happen. The work needs to happen now, because let's be real, it's not like the current administration necessarily has set up structures and systems that perpetuate equity. We know that, right? And so when we look at the alternative, which is just to throw your hands up and do nothing, then we know, right, that that's just gonna worsen it. I'm gonna tap into a conversation that we had during dinner. Hopefully, Ali, you'll be okay with me mentioning this. But as public health, we're here in public health, right? Harm reduction. How many people remember what harm reduction is, right? But we pick the choice that reduces as much harm, that buys us the time to put systems in place that will actually perpetuate equity. And that's the strategy.
Rashid, I don't know, I'm going to call you out a little bit because I knew you do a lot of mentoring work, and I just wonder if you wanted to add anything.
Yeah, I mean, my head is spinning in so many different directions. One, because as a parent of a 7-year-old who's always asking questions, and I'm always curious, and I think always trying to find out, why would you not fight, right? Like, why would you not fight? And my daughter, she's I would say notorious for continuing to fight. Like, she wants to keep going. And I think all I can say is to lead with, like, what I tell her is love, compassion, and understanding, and trying to understand what's going on. The more you can understand, I think, the better you are able to have compassion for a situation, for a group of people. And I think the other thing is leveraging love, like really loving each other, because I think that the generation that you're talking about, I think sometimes they may not always feel a connection, but talking to each other, I think, and sharing in that connection, talking to generations above them, below them, I think that's another thing that I think I always try to promote in everything I do. So the mentoring relationships I have with students, I'm being real with them. I'm telling them my frustrations. I'm telling them my dismay, and also telling them how I show up every day, how I'm still showing up with love, compassion, and understanding, no matter what, because that's all I have. That's the choice I have. That's the intentional choice I make. That's how I respond to my daughter when she's disappointed. I'm like, that's all we can do, right? Is keep going, because I mean, if you're not growing, you're dying. So I'm like, let's continue to grow. Let's continue to push. So that is what I attempt to share with my mentees, my mentors. That's what I try to get from every conversation, is trying to understand more, trying to get compassion, trying to gain compassion, and trying to share love, because to me, that's the only thing that keeps me going, and I feel like it's something that is infectious. Yes.
What I'll add to this is, so absolutely love relationships, I think, are really critical. I sit with this question a bit. It comes up in my undergrad classes that I teach and when I teach at the master's level and beyond. And I think that each generation is inheriting a heavier and heavier world, right, and responsibility. And so I definitely understand that. So what I'll add is that I think we have a lot of work to do in terms of like studying social movements. And it is these younger generations that give me a lot of hope, and I think that there's a lot that we can learn from past movement work, where we're not necessarily sort of copying and pasting that work, but we're like really understanding what did that work look like in context, and what is the unique work that's needed in this environment. I do think that's something that we really need to sit with in public health, in terms of how does that learning happen, and it doesn't need to happen within a classroom, right? Like there's so much learning that can happen outside of the classroom through social media and other sort of community-based learning spaces as well. I very much feel the effects of the current anti-DEI movement, like in the perceived like safety of my own perch in California. And so I think we also need to be thinking about how do we do that teaching within the classroom and outside of the classroom within this context. And I think about the anti-DEI movement as connecting with Nicholas DeGenova's concept of like spectacles, as he helps us to understand deportation regimes, right? That the sort of function is to deport some so that we can control many, right? And similarly, we see like with this anti-DEI movement that what's happening in Florida is not only happening in Florida, Texas, Indiana, et cetera, it's also happening, you know, in California. And so I think we have to get really creative in how we think about what the learning is that we need to be engaging in, and what it looks like in the classroom and beyond.
All right, we have reached the limits of our time, so thank you guys once again. Thank you. So I believe we now have a break for about 10 minutes, yes? Okay, 15 minutes? All right, so these guys are gonna be around. Please grab them if you want to continue the conversation, and then we will resume at 11:30 back in this space.
Check, check. 1, 2, 1, 2. Check, check.
No. Oh. Yes. Hi. Just trying to get everybody's attention. Anybody outside who wants to come inside, please do. I've been asked to make an announcement. Make sure I don't. We do have an overflow room. It appears that there are more people than seats. So there is an overflow room on the 3rd floor. It's right behind the sign, I think, for our department, our newly named department. And if you really need to know exactly what room number it is, because I don't know what it is, the front desk can tell you where it is and where to go for the overflow room. Is that okay? Okay, thanks. I am Mark Zimmerman. I've been here a long time. I think come January, I might be the longest serving person in the department, but right now I'm not. I'm going to introduce the next group. We're going to have 3 projects in the department come and speak to you. I'm talking about as if they're not real people. Health Equity Project Showcase. And I'm going to, this is kind of how we kind of organize this. I'm going to introduce everybody. I'm going to read their bios really quickly. And then each group will come up front to do their presentation. And then at the end, we'll open it up for Q&A. Does that sound good? Okay for everybody? Okay, so the first group, and you can hold on, you'll come up when I finish introducing everybody, okay? All right. The first group is Love Her Collective Community Academic Partnership, Christy Gammerl, Harmony Harris, and Laura Chadwick Chakmak. Did I do that better? Did I do okay? Passable? Chakmak? Christy is Associate Chair of HBHE and Research Associate Professor in the Population Studies Center at ISR. And her work has focused on addressing health inequities among LGBTQ+ communities within the context of HIV, mental health, substance use, and healthcare access. Her research is largely focused on community-based principles and in the development and evaluation of community-engaged interventions. She is the founding member of Love Her Collective, which you're going to hear about, which is a community academic partnership with Trans Sisters of Color Project in Detroit, and she collaborates on initiatives focused on trans health equity across the United States. Harmony Harris, one of her community partners, is health manager at the Ruth Ellis Center and a member of the Trans Sisters Color Project. As a member of the Love Her Collective Community Academic Partnership, Harmony has co-developed and served as a facilitator for Kicking It with the Girls. You should know that girls is spelled G-U-R-L-Z, which focused on healing from trauma and taking care of your whole self, and now co-developed and facilitates Secure, S-E, capital C-U-R-E, just so you know how that looks, a microeconomic program for trans women of color in Detroit. And then Laura is the research director for the Resilience and Resistance Collective research team in our department. I love, by the way, that we can still say HBHE. That's kind of cool, isn't it? I don't know whoever thought of that, but Laura conducts, say again? What'd you say? It was Arlene. Thank you, Arlene, wherever you were over here. Somewhere, I don't know where you are now. Laura conducts participatory community-centered research with and for LGBTQ+ communities focused on qualitative and mixed methods inquiry, intervention development, and evaluation. She's a founding member of the Love Her Collective, and I already mentioned that, in collaboration with the Trans Sisters Color Project. She's also collaborating with LGBTQI organizations in Kenya. That's probably working with Gary, wherever he is sitting. Oh, there you are. with a common aim of reducing health inequities in HIV, mental health and substance use, and healthcare access. The next project, and we'll go in this order, right? Is that okay? The next project is Amy Schultz and Angela Reyes. Amy is the University Diversity, that rhymes, I never actually said that out loud. University Diversity and Social Transformation Professor, is trained as a sociologist with her PhD, but she has an MPH too from our department, with expertise in joint contributions of social and physical environmental exposures to health inequities, and is a leading scholar in the field of community-based participatory research. She has extensive experience working collaboratively with community, practice, and academic partners to conduct both etiological and intervention research to understand and reduce health inequities. My mother would be proud that I was able to say etiological without tripping over it, a second time even. Her current work in community action to promote health environments, or how do you pronounce that? Do you have a cafe? That's what I was going to say, but that didn't, cafe. I didn't know that. Which is a CBPR partnership focused on air pollution, social and economic inequalities, and exposure and impacts, implementation and exposure. Implementation of components of cafes scientifically and community-grounded public health action plan to reduce health risk in the Detroit metropolitan area. Her specific expertise is in analysis of joint contributions of social and physical environmental conditions to racial and social economic inequities, development and implementation of policy programmatic interventions, conducting health impact assessments of proposed policies, and the engagement of community, academic, and public health practice partners in her work. Angela Reyes, who is a longtime partner in the department and the school, is a founder of and executive director of the Detroit Hispanic Development Corporation, a community-based organization focused on youth development. After forging a truce between leaders of rival gangs in Southwest Detroit, the corporation created the Gang Retirement and Continuing Education Employment Program, also called GRACE, focused on retiring gang members and placing them in jobs in local Latino-run manufacturing companies in Detroit. The corporation's mission continues to make a difference by creating life-changing opportunities for youth and their families, providing quality, innovative, and culturally appropriate services in Southwest Detroit. She's an alum of our school, a founding board member of the Detroit URC, and we'll hear from Barbara, I think, a little bit later. Since 1995, a founding member of the Community Action to Promote Healthy Environments Partnership since 2013. Angela is a recipient of several awards, including Corp Magazine's Michigan's Most Influential Hispanic Leaders, New Detroit's Closing the Gap Award, and the Detroit Metropolitan Bar Association's Liberty Bell Award. Angela is known nationally and internationally as a consultant and speaker on issues affecting Latinos, including cultural awareness, youth gangs and violence, immigration, and education reform. And finally, Rashanak Medapana will be talking about housing solutions for health and equity. Rashanak is associate professor in the department and director of the Housing Solutions for Health Equity Initiative, focused on informing local, state, and national policy through interdisciplinary research on housing as it relates to equity in health, race, socioeconomic status, and aging. She's also co-lead on the Public Health Ideas Initiative, creating healthy and equitable cities, and is the contact PI for the newly funded, CDC-funded Prevention Research Center. Her research focuses on how urban policies, particularly related to the built environment, affect health and health inequities in individual neighborhoods and cities. And she's helped develop an understanding about housing as a determinant of health, and has established how housing instability exacerbates health risks. So with that, I will call up you guys, Christy et al., and then we'll follow with Amy and Angela, and then Rashanak. Thanks.
All All right, so I teach in this room, so I'm going to try to not be long-winded. All right, so I'm Christy, she, her pronouns, and we're so happy to share with you our experiences in developing the Love Her Collective. Whoop, it's working. So we're going to introduce our partnership, tell you briefly about some of the work that we've done together, and share a little bit about our lessons learned.
Hello, everyone. So a little bit of information about the Trans Sisters of Color Project. It is a nonprofit agency created by black and brown trans women for black and brown trans women. The mission is to uplift and impact the influence of the lives and welfare of trans women in Detroit. And also, we create and develop trans-centric programming projects and services that build individual and collective power and agency amongst trans women of color. And also, just a little bit more background information about TSOCP. It was created in 2014 due to the horrific violent death of one of our trans sisters, and there wasn't any justice from that. So a group of trans women, and shout out to Brianne Campbell, came together and developed TSOCP, and here we are today.
So in 2018, we started initial partnership meetings that were supported by the URC between Christy and I and members of TSOP, focused on understanding one another's priorities and building trust. And together we began to build the Love Her Collective to understand and address the needs of trans women of color in Detroit. So this is a picture from our first community advisory meeting. And this is our amazing team of collaborators based both here in HBHE and at Trans Sisters of Color Project. And so we started by conducting mixed methods formative work to understand community needs, including a series of focus groups in 2019 and a cross-sectional survey in 2020. And a common theme that we heard from the community was a lot of frustration that most research or programming that was focused on trans women focused exclusively on HIV while ignoring their overall needs and unique experiences that trans women of color have. At the same time, trans women of color, as Harmony mentioned, in Detroit were experiencing pervasive trauma and violence and extreme economic vulnerability. So with our time with you today, we're going to briefly introduce 3 of our projects that we've developed together based on these community priorities.
Okay, so our first program, called Kicking It With the Girls, focused on helping trans women of color heal from trauma and take care of their whole selves. There are 3 components of this intervention. The first was a screener, which was to help assess the needs related to housing, safety, and violence, and of course, gender affirmation. Second was individual one-on-one peer navigation to confidently connect partners, participants to healthcare and community resources. And lastly, we hosted 8 weekly group sessions that our team adapted from the Seeking Safety program. And these were some of our group, well, all of our group sessions that we facilitated each week. And we also knew the importance of representation. So we were very intentional to include black and brown trans leaders so that our participants could see themselves in other roles as well. Yes.
You got one more on this page.
Okay, yes. So in total, we ran 7 cohorts of the Kicking In With the Girls with a total of 38 participants. We had good attendance, and most of the participants stayed in the program and completed research activities. We also saw improvements in HIV care, a decrease in intimate partner violence, and an increase in gender affirmation outcomes. Overall, we found that Kicking It With the Girls is a feasible and acceptable intervention with preliminary promise. We are now thinking through next steps on how to scale up this program. And lastly, participants appreciated the program, that it went beyond HIV and focused on topics relevant to their lives.
That's okay. Yeah, all right. So the next project that we want to introduce is called Strengthening Community Responses to Economic Vulnerability and HIV Inequities, or SECURE. You can see our lovely logo there for Secure in the Bag. And so Secure really developed out of community-led safety net programs. So since 2014, TSAP has run an emergency assistance program that provided no strings attached financial aid to trans women of color in the community. During COVID, we received additional funds to supplement the emergency assistance program, and we did a program evaluation where we learned that how amazing and helpful these emergency assistance funds were in folks' lives, but also that they wanted more opportunities to learn about finances and credit, receive mentorship, and get professional development opportunities. So this led to our development of the Secure intervention through an R34. Participants in this program receive $250 in emergency assistance, are connected to legal gender affirmation support, attend 12 weekly group sessions that we developed together focused on running a micro business and improving their finances. They're connected to a mentor in the community, and they receive no strings attached $1,200 that they can invest in their own micro business or other professional development goals. So we are currently testing out the Secure intervention using a waitlist control design. We have enrolled all of our participants, and we're currently like 3/4 of the way through the group sessions. And please come see our poster on Secure this afternoon to learn more and meet more of our Secure team members. And now I will pass it back to you.
All right. On. Stole this one. So I'm gonna last talk about breaking barriers to legal gender affirmation. And this project is really focused on legal gender affirmation. And for those who don't know, legal gender affirmation is changing one's legal name and gender markers on your identity documents to match who you are. And what we, doing it so well for everyone else. So it's really so when we think of gender affirmation, it's the social recognition of one's gender identity, expression, and roles, and we can think of these in many different domains. What we know across the literature that unmet gender affirmation needs leads to a host of adverse health outcomes, social vulnerabilities, experiences of discrimination. And so our good colleague, Julissa Abad, who's a member of the Trans Sisters of Color Project and also the Love Her Collective. So this is what you're seeing here is the name change process in Michigan. You can see it's many arduous steps. It's paying money. It's showing that you don't have a criminal record. It's going to court. It's a lot of traumatizing experiences. And Julissa has worked really hard to create the trans name renaming program. It provides name change services with no fees to the community. Since 2000, I think it's about 600 people that she's actually had changed folks' names, but barriers exist. And she came to us and explicitly told us that she was struggling with people who had a criminal record. And so we worked together with her, and we were able to secure funding. Because in the law in Michigan and many other states as well, I don't want to say that Michigan is alone in this, but applicants with a criminal record have the burden of proof to rebut a presumption of fraudulent intent. And we've heard a lot today about structural racism, and I want to lift up intersectionality here and the ways in which Black feminists have spoken about the ways in which we can see these policies sort of collide, right? So what we did with her, and we got funded through the Anti-Racist Catalyst Grants, it's an incredible mechanism. The program components were that a lawyer would represent the participant. So this was sort of a medical legal partnership housed at Corktown Community Health Center to represent the participants with legal issues, peer navigation, where Julissa was actually housed there and linking people to services. We had funds to pay for those legal fines, and then they were to be connected to the trans renaming program once all those outstanding charges were addressed. And that sounded beautiful, right? Well, there were a lot of challenges. The legal barriers there were a lot of them, and most of them were monetary sanctions. So colorblind enacted racism, in which people were getting low level, oftentimes vehicular infractions, so driving with expired plates, a parking ticket, all of a sudden you can't pay that fine and you're incarcerated. So people could not show up to court to get their names changed. The unpaid fines continued to increase, and they were exorbitant. We were seeing that people had thousands and thousands of dollars across different jurisdictions. And individuals, of course, needed to continue to get tickets because of that transportation issues that we have in Michigan in general. People needing to get to work and take care of themselves. We're now working with the ACLU. Jay Kaplan is incredible to try to change the name change process in Michigan and remove some of the arduous barriers. And we are put in a proposal to continue Julisa's amazing work. So we want to leave with some lessons learned. First, we have been working together now for 6 years. Lots of lessons. The first, and I just want to, this really echoes the whole theme of this work, that we need to ensure community leaders are at the table and they're leaders in this work, but they are adequately resourced to do this work. And beyond just literacy and sharing information back, but they actually have the funds and resources and professional development. Creative ways to respond to community needs. We have had to be very creative in a lot of different ways. Happy to talk more about that. We've also all had to be vulnerable with each other and have really hard conversations to build trust and continue that trust. We've had to use trauma-informed strategies in every single aspect of this work. All of our work has been about supporting and investing in community-led programs and thinking about how we as researchers dedicated to health equity can use our tools to enhance that work. And while our work is very much on helping navigate people's systems of oppression, we are also dedicated towards working towards structural change. As an example, working with the ACLU. And Harmony had one last thing that she wanted to share.
And lastly, we learned that it's very intentional that when going into this work, this isn't just like another research project or something like a thesis that you have to get done. You're working with real people with real lives and real trauma. So when going into this research, again, be intentional and empathetic because you don't know the adversities that one face. And even though someone could be smiling, they can have nowhere to go. So again, when doing these type of research projects, just be intentional. And if you just need to get a project done, do research on public transportation.
Yes.
So we just want to acknowledge our larger team, all of whom have come together to support, sustain, and push one another. This partnership and our work together, as well as the participants and board members who give us their valuable time and energy to this project, and of course to our funders for investing in the work in this community. Thank you.
Hello. Okay, great. Good morning, buenos dias, or afternoon. I think it's almost afternoon. Again, my name is Angie Reyes. I'm one of the community partners in this project, CAFE, Community Action to Promote Healthy Environments, and I'm co-presenting with my colleague and good friend, Amy Schultz. And I'm really delighted to be here today. There's so many people that I know. I keep telling people here at U of M that I need an office here, but Still haven't found one. So we wanted to present today a little bit about this project that we've been working on since 2014, 10 years now. That is a partnership that's dedicated to both procedural and distributive environmental justice and health equity. Where's the button? Technological things. So this is, these are the logos of all the various partners that have been involved in this project over the past 10 years. As you can see, there are a number of community-based organizations from across the city of Detroit, mostly in Southwest and the east side of Detroit, as well as the University of Michigan, and both state and municipal government entities that are all reflected in this, on the logo slide. We've been working to address air pollution in Detroit, and the work builds on the work of many environmental advocates over the years. Those of you who may be familiar with Detroit know that there are a lot of active EJ folks in the city. So working with a number of those folks, as well as 3 pre-existing community academic partnerships focused on health equity in Detroit. So the Detroit Urban Research Center since 1995, the Community Action Against Asthma, which began its work in 1998, and the Healthy Environments Partnership, which started in 2000. So each of these 3 partnerships came together to focus on this work around air pollution and air quality in the city of Detroit. So historically, Detroit has faced a number of challenges around air quality. There's multiple pollutant sources, large exposed populations. A lot of the zoning puts a lot of the populations, residents, in very close proximity. A lot of disproportionate levels of adverse health outcomes that are associated with the pollutants, including asthma, cardiovascular risk, adverse birth outcomes. And because of the proximity of industry and manufacturing to neighborhoods, there's a large number of residents that are very vulnerable disproportionately to all of these exposures. And this picture is of a playground. What you can't see is immediately to the right of it is the I-75 freeway, that bridge that's over there. This playground was originally a little bit closer to the ramp, but they had to move it because a semi-truck fell off of the freeway onto the playground and caught on fire. Thank God there were no children there at the time, but that tells you just how close community residents are to a lot of the dangers that exist in our community. Water treatment plant, yeah. So a lot of pollution in this area, which is also located very close to where the new Gordie Howe Bridge is being built. So this part of the Southwest Detroit community has been hugely impacted by a number of pollutant sources. So since 2014, CAFE has been working together. We're building on the strengths in our community because we also have a lot of strengths and resources toward creating and implementing scientifically grounded and community-informed and led actions to reduce adverse impacts of air pollution for health. I know that was a mouthful, but in other words, the community has been working together with academics to be able to make changes in our community. And these are some of our overarching goals here. So at the core of our work for CAFE, it really is equity. How do we address the inequitable impacts of pollutants on our community? So the equity is included in our processes, in our research, and in the actions that were developed. And we really work together in a collaboration to promote all of the actions that we take. There's a shared decision-making model at all different levels, evaluating the strength of our efforts, ensuring that Detroit residents have a substantial voice in identifying and creating solutions to promote clean air and health equity. And this has been both part of our environmental justice movements as well as some of the values in community-based participatory research. And we use the principles of community-based participatory research, which many of you are familiar with, which are here up on this slide.
All right, so we're going to give you just a really fast tour through some of the work that we've done together over the last decade or so. Our work in CAFE unfolded in multiple phases, and the first phase, we were really focused on building the partnerships, strengthening the relationships between all this big, actually a pretty big group of characters that are all part of our steering committee. We also use that initial time to develop the scientific evidence base that underlies the recommendations that are in our public health action plan. So the first 3 years that we worked together, we were really developing that foundation. And in 2017, we launched our public health action plan. Sorry. So first, we quantified and mapped the exposures throughout the city so we could identify some of the predominant sources of air pollution and also the predominant communities that were being overexposed to multiple sources of air pollutants. And as you see, this is one of the things that we talk about a lot, actually. Each year in the Detroit metro area, air pollution is responsible for 690 deaths. 1,800 hospitalizations and emergency room visits, and thousands of missed school and work days because kids go to school, they have an asthma attack, mom, their parents have to come get them, take them to the emergency department. We monetized the cost of that. I don't love putting dollar amounts on people's life and health, but one of the reasons that we did this is that we anticipated that as we went to talk to policymakers about making changes, that they were going to ask questions about how much it costs, and we wanted to be able to talk about the fact that not doing anything costs money as well as there are costs to people's health. So that was one of the first things that we did. We also, and we published on our website our resource manual, which has all the background science in it. There's a couple of examples, but it shows the distribution of pollutants in the community. It shows the primary sources and the amount of pollution that each emits. And we wanted that to be a resource for community advocates who are working on these issues within the city. So this is just some of the background work. And then we developed a set of recommendations. And the recommendations were grounded in work that's been done across the country by communities similar to Detroit to get their air pollution under control. Because we wanted really practical and actionable recommendations. So we took a draft of those recommendations out to a series of community meetings. You can see some pictures here from some of those meetings. That's Angie's shop at the top picture. And talk to residents. And we said, this is what we're thinking about recommending. What input, what feedback do you have on that? And that feedback then ultimately was all folded in to the Public Health Action Plan. And this includes 25 recommendations that we think are very actionable, things that can be done by local Detroit residents and local government to reduce air pollution within the city. You can see this is a picture from our launch. Angie's at the podium talking about air pollution, right? And then since that time, what we have done is work on implementing the actions that are recommended within the Public Health Action Plan. The ARA program here is actually something that was founded by another one of our amazing alum who works in Dearborn. And it is a program that started for high school students to learn about the science of air pollution and also learn about how to do policy advocacy around it. We have now taken, I should say her name, Natalie Sampson, is the one who started this. This is a photo, the bottom photo is a group of the youth who do this intensive summer program. One of the really wonderful things we've been able to do over the last couple of years, and is Arisha in the house? Arisha, raise your hand. Worked on this, is we took the ARA curriculum, which is designed for high school students, and we've now created a module that meets the next generation science standards for middle school students, and we are promoting that out to middle school teachers to do in their classrooms. And so it's that's been a real exciting movement. Yes?
I just wanted to point out that our wonderful U.S. Congresswoman, Rashida Tlaib, is also in this picture.
Yes, a great supporter. You do this one.
Yeah. So another component that we're working on implementing is the SKIP program, or the School Indoor Air Project, is putting air filters in youth-serving organizations and schools, and monitoring what the impact is, what the condition of the air is, and then looking at what happens once you put a filter in and improving the indoor air quality.
The last thing we're going to really quickly highlight here is our our policy advocacy training, and also our mini grant program. So we do policy advocacy training for community members who want to advocate on behalf of their community. This is a program that was initially developed by the URC. We have adopted it and do work primarily training around advocacy around environmental issues. We also have a mini grant program that is for community residents who want to take action within their communities. They can apply for up to $5,000. They're itty-bitty grants, and people do amazing things with that little pot of money to address air pollution issues within their communities. And again, Arisha runs that program for us, so thanks, Arisha. Okay, and just a final slide to acknowledge all of the people who make this work possible, all of the partners in Detroit who have been working with us on this. And thanks to our timekeepers for keeping us on time.
Hi, everyone. All right. So hello, everyone. Thank you for having me here today. I'm going to be talking about the Housing Solutions for Health Equity Initiative. And just a shout out to the PRC collab team up there who make my life a lot easier every day. So before I get started on the initiative, I do want to set the stage a little bit. The health of our cities depends on the quality and accessibility of housing. Housing is not merely shelter, it's a foundation upon which individuals and communities build their lives. It shapes our neighborhoods, affects our health, influences our education, and impacts our economy. Therefore, housing is a determinant of health, a multidimensional determinant of health that encompasses affordability, access beyond monetary means, and the conditions or its quality. So housing is unaffordable for many Americans. In fact, last year, 1/3 of Americans were spending more than 30% of their income towards housing costs, including rent, property taxes, mortgages, and utilities. Purchasing a home is increasingly out of reach, with the age of first-time homeowners constantly climbing. The housing stock is aging, with the majority of homes now being built prior to the 1980s. And housing is interconnected with other determinants. We are seeing commute times increasing as people have less access to affordable housing within cities, and we're seeing food insecurity is rising. However, this is not a one-day event, or it's not a crisis, as everybody alludes to, as there have been structural forces that have created and continue to reinforce these neighborhood inequities and housing inequities. Inequitable distribution of resources by cities and counties has led to some neighborhoods having greater disinvestment, less resources and such. And we know that a greater proportion of non-white racialized groups, particularly non-Hispanic Blacks and Hispanic Latin people, are affected. So this set the stage on why it was critical for us to have a housing-focused research group here at the university. And in 2021, we established the Housing Solutions for Health Equity, or HSHE, where we envision a world where decent, safe, affordable, and healthy housing is available to everyone. HSHE informs local, state, and national policy through interdisciplinary research on housing as it relates to equity in health, socioeconomic status, race, and aging. Our values are data-driven research with a focus on equity, a reciprocity in relationships, and the sustainability of both the research and the partnerships. We work together to advance interdisciplinary and community-engaged research. We produce research that informs local organization and government agencies, and we aim to train and support students, researchers, and faculty members in this work. So this is our team. Shout out to our program manager, Malika Belhaj, who's currently presenting at another conference, and Kate Brantley, who's our research area specialist, and many of our students that have taken part in the initiative over the years. The HSHE brings together a group of over 20 interdisciplinary experts from these schools. And our partnerships expand, this is just a snippet of it, but both internal partners from across the university and external groups that we've been working with at both the state and local levels. Every year we have a speaker series where we feature work by researchers at U of M and together with a community partner who's working or a practitioner who's working in those areas. And we have a set of funded projects. So I want to highlight two here today. This was a recently published study by Alexa Eisenberg and Kate Brantley, focusing on record costs to study the costs and consequences of eviction filing for Pennsylvania tenants and their families, to really show the collateral cost of eviction filings for tenants over time. And if you are interested, we will be having a webinar on this on Friday, October 18th. The other project that I want to showcase is Communities in Context in Detroit. Big shout out to Trish, if she's still here, and Rashid, and our team here, where we studied housing and mental health needs among Detroiters, aiming to help inform future public health actions by engaging residents and social services providers. And again, a big plug if you're at APHA, Kate Brantley will be presenting on this work. So I do want to showcase something that I am extremely proud of. It was 3 years in the making, and it involved multiple groups coming together to develop the updated Michigan statewide housing needs assessment and working in partnership with the Michigan Statewide Housing Development Authority, which is the state department that oversees housing. So this report, it's a comprehensive report examining the inventory, demand, affordability, and instability and homelessness using a health equity lens. And it was so important for public health to have a voice in this because housing is a determinant of health and should be present in those conversations. I think this morning there was conversations about health in all policies, and this was a great example of it. So I'm going to present some findings that have been connected to health in the literature. So from 2012 to 2022, the homeownership racial gap has held steadily. 79% of white households are homeowners in the state, while 45% of black households are homeowners. That's a 34% point gap. And this is slightly higher than the national rate of 28.7%. The results of this what we're seeing here are a result of historical and contemporary processes, including redlining, mortgage lending discrimination, fair housing related issues, and generational wealth development. I also want to point out the median household income gap between owners and renters has held steadily over the past 10 years, where the median income for homeowners compared to renters is a $40,000 difference, almost 41. And we know that the rising costs of rent possess challenges for renters who are already have lower household income. And this signals a very clear challenges for mobility from renting to home ownership. making it very difficult for folks to become first-time homeowners. In the state, the median price of a home has increased 50% from 2012 to 2022, with a large increase in the last 2 to 3 years. But we know that wages have remained stagnant, and so more and more people are not able to afford housing. We know that half of renters in Michigan are cost burdened, meaning they are paying well over the 30% of their income towards housing. And we know that of that half, 1/4 are severely cost burdened, paying more than 50% of their income towards housing, while 1/4 of homeowners with mortgages are considered cost burdened and paying more than 30%. But if we look at these numbers a little bit more closely, we see that 88% of those with a household income of $20,000 or less are considered to be cost burdened, while 56% of those with a household income between $20,000 to $35,000 are considered cost burden. This means that those living with the lowest incomes are experiencing the detrimental costs of housing. And most individuals working at a minimum wage in the state are falling into this category, or in the one above it if they are living with a partner, showing that they're allocating more than half of their income towards housing costs. Now, I do have some good news. So we know that the number of tax foreclosures across the state has gone down, and this is attributed to many programs across the state that is supporting property taxpayers and tax payment plans. So that is a good thing. However, those are owners. What we're finding is that eviction filings have increased to 38% from 2021 to 2022 after a significant drop in filings in response to the COVID-19 pandemic. And for those who aren't familiar, the eviction filing refers to the first step of the eviction process, which is the filing of an eviction complaint within the court. And this filing comes with court costs such as filing fees. And we know that approximately 20% of these filings actually lead to evictions. So these are important findings. Oh, sorry, and I have one more. And we know that homelessness has dropped slightly, but is on the rise again. However, it's important to note that the data set where this data comes from does not account for folks living in someone else's home on couches or doubling up in residencies. So I want to thank our many partners. We have an upcoming event next week in Detroit. If you are around, please come and join us. And just really reiterate that housing is a determinant of health. Believe it or not, even till today, I still have to make that claim in many spaces. And hopefully today you take a piece of that and share it along. Thank you.
Why don't you all come back up front? Don't go away. We have about 12 minutes between you and lunch. We can go a little bit further if you'd like. But what I want to do is just see if there's any questions and or comments or thoughts from anybody, from folks here. You don't count yet. Let's just, you had your moment. Let's just see if there's anybody else. And if there isn't, I'll be happy to. And you have another microphone, so you're going to take, I didn't pay for these microphones. Any comments or questions? Yeah, Elise.
So thank you all for your presentations. This is about housing and aging. So we know that we have the baby boomer population, which obviously in terms of cohort is pretty large. And they're starting to come, oh, thank you. Am I not being loud enough?
No, it's being recorded. So
oh, okay. Sorry, thanks. So I'm curious about, as we think about the baby boomer population and the fact that they're aging and that they own, a lot of that population does own homes, and those homes are probably, homes are built, around the 1980s, as you were saying. What's the planning around what happens if we do start to see more homes opening up, and are there opportunities to proactively plan before those types of shifts so that we can then not be kind of responding to, oh my gosh, we have people moving into houses that are derelict and have kind of maybe having materials that aren't as safe. Like, is there kind of forward looking at this point, and what does that look like?
Yes, that's a great question. So it's twofold. One is repairs and one is modifications, right? So in terms of repairs, there are programs out there, but they're mostly focused on homeowners. So that's part of the lacking piece there. However, I think there has been a realization most recently that there aren't enough assisted living units, there aren't enough places for folks to go to, so they have to age at home. And to do that, Medicare, for example, has teamed up to allow some level of retrofitting of homes. And then the other side of it, which we're studying in Corpus Christi, Texas, is that much of the modifications are focused on physical modifications, so due to physical barriers that people might experience. However, there's a whole element of cognitive barriers, and what we want to uncover is what are some of those cognitive barriers. As more people cognitively decline, we want to be prepared to retrofit homes to address those needs too, which are quite different from physical barriers.
Thanks. Anybody else? No one's going to say anything because they want you to, go ahead, yes.
Now I'm thinking of two different presentations. One, could you tell us what the Trans Sisters of Color and the Love Her Collective have coming up next? And then I'm also thinking, like, Rashanik, of your presentation, and like, what does your partnership think about in terms of like housing for trans women? What does that look like? What are some struggles? Yeah.
So far what Trans Sisters of Color Project is doing to combat the housing instability for trans women of color is that we just got this big grant from the state, this Health Disparities Grant. Shout out to Janice Poindexter because she has real close connections to the governors and other politics who hear our needs as far as the adversities faced within the community. So we did get this grant, a Health Disparities Grant, and we can't house anyone, unfortunately, but what we can do is provide temporary housing. So a part of our unrestricted funding that we do have is that we have the ability to house girls for up to several weeks in a hotel room. We're still working with the governors and the powers that be to create more sustainable housing, but that is one of our biggest challenges, unfortunately. No problem.
I really admire what the Love Her Collective is doing, and I know we've had conversations with Christy. One of the areas that we think is really important is the medical legal partnership and bringing in the housing resources to that. And as successful programs or ones that we often showcase and want to talk about is also the Ruth Ellis Center and their housing program. So yes, maybe this is the time. Can we work together? Let's do it. Yes. Thank you for that.
So Amy had a question, so moderating to her.
Thank you, Mark. I only wondered why there's a missing data point for 2020 in all your slides.
So most of our data came from the ACS, the American Community Survey, and in 2020 that data was not collected and at that level, so we're missing data points.
Did something happen?
I actually have a question for you two ladies. By me being born and raised in Southwest Detroit, I have seen the redevelopment of it. However, Southwest is pretty big. So I wanted to know what areas of Southwest particularly are you working on? Is it Del Rey, Mexican Town, or just like all encompassing of Southwest?
It's really all of Southwest because air has no boundaries. The primarily impacted communities are really Del Rey with the Gordie Howe Bridge and the dislocation of community members, and also 48217 because of its proximity to Marathon and DTE, who are some of our biggest polluters, but really all of Southwest has health impacts that are disproportionate to even the rest of the city because of the air pollution.
Thank you.
And we're currently doing a health impact assessment of the Gordie Howe International Bridge to try to understand what are the health impacts of putting that bridge into the community. I want to give a shout out to the GHIB survey team in the back. It's working really hard on that one.
Thank you.
Anybody else? Any other comments or questions or thoughts? Yeah.
I wanted to ask, I saw recently that Michigan is going to lift some of their restrictions on transporting hazardous materials across the bridge. Have you all been working to kind of see what that would look like and the impact that might have on residents?
That's the Ambassador Bridge, the existing bridge, not
The privately owned bridge. Yeah, so that is something that the community has been testifying a lot against that, and it looks like there's some movement now amongst the legislature to prevent some of that from coming over, but it's an uphill battle because, you know, it's what they play like whack-a-mole, because we get one thing taken care of and something else pops up, so it's a constant struggle. You can't sleep on this stuff because there's always something.
Anybody else? Yeah.
This is for the Love Her Collective. I'm just curious to hear a little bit more about your domestic violence interventions and how that can be successful, because I know that's a huge problem in Detroit at large, and especially for trans women of color.
So I can talk a little bit about it as far as like the boots on the ground work that I do as far as helping to decrease intimate partner violence. So because we have connections with Jaleesa Abad, another member of TSOCP, she works for Fair Michigan, and she has a lot of legal connections that can help trans women of color facing those issues. So whenever we do have a person who does confide in us, we just refer them to Jaleesa Abad.
Now, just to make a note that Julissa, as part of her work, has done a tremendous amount of trainings across Detroit, especially, actually many different places, the U.S., in training law enforcement in particular in how to respond to domestic and IPV that happens, and the discrimination that trans women experience, trans people experience in those settings as well. We're happy to share more about our program, but I feel like Julissa's work is fire.
And I'll just add that our Kicking It With the Girls program that Harmony talked about in her presentation, and she was one of the facilitators and co-developers of the program with us, that really was focused on helping folks heal from trauma. So that included topics around IPV and other kind of issues of violence and stigma that folks were facing. And so that was kind of a space for women to come together and have that healing space together. And then the one-on-one peer session, peer navigation that Harmony and our other colleagues provided was able to like confidentially and privately connect people to the resources they needed. So if they weren't comfortable kind of sharing all those details in this group setting, there were those one-on-one connections where people could kind of get then linked to the services that maybe they didn't realize before the groups that existed, or that they even were kind of needed that support.
Okay, it's about time. So I just want to say thank you for all the presentations and for the community partners who came. And to the committee who kind of organized this, when we think about what we're here for, we talked earlier about space, housing, environment, what's more relevant than that, right? And we talked about disadvantaged or invisible populations. And then it was really cool that we had a network opportunity right here. So I'm going to do one last little commercial, and that is, you know about these projects, you know who they are, if you have some interest, and especially students, if you have some interest for doing any kind of work, I'm sure I speak for my colleagues to say, knock on their door and see how you can contribute to the work that they're doing, because we always can all use help in advancing these important projects. So thank you for your attention. I thank you for our colleagues, and lunch is next door. Am I right about that? Lunch is next door, so join us for that as well. And then there's the afternoon. After that, we'll have our keynote address from one of our distinguished alumni. So one more of our distinguished alumni. Anyway, thank you.
Hello, hello, hello. Hopefully everyone had a good lunch. I see some new faces, so welcome in. We're gonna get the second part of the symposium underway, and I'll hand things off to Barbara to introduce our keynote speaker for the afternoon.
Thank you so much, Daryl. Thanks so much. Hi, everybody. Welcome. Delighted to be here. I'm going to say a few words about Jesus. Delighted to do so. Ramirez-Valles. You have his bio, so I'm not going to read it all. I'm just going to highlight a few points. He is a PhD and MPH, both from our department. He's an accomplished scholar, academic, filmmaker, public health leader. He's chief of the University of California, San Francisco Division of Prevention Science and holds the Walter Gray Endowed Chair in HIV/AIDS Science of the AIDS Research Institute. And his work is rooted in social and behavioral sciences, focused on health equity and community engagement. And I would just like to add, Jesus was one of my former doctoral students. I had the very good fortune to work with him for a few years, and a couple of anecdotes, which we've already talked about over the last couple of days, one of which Jesus originates from Mexico, and he complained about Michigan weather the entire time he was here and said he couldn't wait to leave, and as soon as he graduated, he was out of here, and he went and proceeded to live in Chicago for 22 years. But he has now found a wonderful place in California, which I'm assured he much prefers the weather in California to Chicago. The other thing is, when his last year of his dissertation, I was on sabbatical in New Zealand, and he still talks to me because he had to send documents via Federal Express because there was no electronic mechanism back then in 96, 97 when he graduated. And like I said, we still survived that process and have thrived and been good friends ever since. So you're in for a real treat. I thank the planning committee for selecting Jesus to come, and thank him for joining us today. So Jesus, my pleasure.
With this one, and I have to pay to send those FedExes from my pocket. FYI, I told Barbara, she says, I'm sabbatical. I said, I have a job offer here. I need to finish this PhD. So I must begin with great gratitude. Dr. Hassan, thank you for hosting us. Scott, thank you for inviting me, assuming me, and welcoming to this. And of course, Dr. Caldwell, thank you for leading this vision and this new name that today we celebrate and inaugurate. Thank you. And I think the Bowman is joining us soon, so tell him I said thank you. It's always great to be back in Ann Arbor with good weather, that I don't have to sleep on the snow. Seriously, I owe so much to this institution and to the many people who put their hearts on it and make it a lovely, lovely place. I must start with our late Noreen Clark. She supported me in my MPH and my PhD program. I'll tell you an anecdote. I was going to do my fieldwork in Mexico, and she loaned me her old laptop. Imagine laptops in the mid-1990s. These things. So I was traveling. And more importantly, she used to teach at the first introductory course for the MPH program. And she made me feel at home, not only because of her presence, but on the reading list, Paulo Freire, Pedagogy of the Press. The book I have read in college in Mexico, and I was like, okay, I know this, I can do this. And of course, I have to thank Mark Zimmerman. He taught me how to write in English and how to write academic papers that I still do today. Thank you. Barbara, of course. Barbara that provided me the foundation for community mobilization and qualitative research. I have published 2 books based on ethnographic work, and I still think of how Barbara is thinking about them, what critique is she having to offer. And of course, you know, so many people that I can go around the room. I'm so fortunate to call them now my friends and my colleagues. Thank you. So of course, coming here for me is like a homecoming, right? One day, I was in your shoes, sitting right there, immigrant from Mexico from the border, a product of affirmative action, and a young brown gay man with a lot of anxieties. I remember those anxieties. Okay. I did agree. The other green. So there are two greens. But of course, a more famous gay immigrant, Christopher Eschergood, put it in better words than I did. And this is how I felt. The way he put it is, I feel free here. I'm on my own. My life will be what I make of it. And that was me in Ann Arbor. Ann Arbor was the foundry where I live today, where the life I live today was forged. And this is school where I started my career as an academic, as a professor, and as a member of the global public health community. But sitting here and listening to other conversations, I wonder for how many of you are new to public health? Yeah, first semester? Welcome, welcome, welcome to our community. Our community is wonderful, but it has this singularity. We care about the health of our populations, which can only happen when opportunity and access to healthcare is equitable to all of us. Here in these walls is when we explore what I think are the basics, the foundations of public health, which is, of course, social behavioral change, communication, evaluation, assessment, and of course, the social determinants of health. Those fundamental basis of public health are the basis of our scholarship, and they take in a deeper meaning when we think of the macro in public health. But even bigger is when we think about the micro, which is the individuals, the people, the communities that comprise that public health. Embracing the challenge of health equity, I believe, can be supported by adding a humanistic perspective into our practice, into our teaching. I believe it's important to add this leadership perspective in our discipline in order to achieve health equity. To me, of course, it's a great honor to be asked to speak in front of you here today, but also it's my duty. Yeah, it's really, I feel like my duty. I feel like it's my responsibility as a senior older person to pass the knowledge that I acquired not only in these walls, but in the 30-something years of my career. What we call generational health, generational wealth, but for us is generational health. So hopefully that will be passing on to you. And of course, I love the name of our new department, Health Behavior and Health Equity, given our emphasis, evolving emphasis on health equities, in our research, in our teaching, in our service. I'm gonna go back again to Paulo Freire to remind us of why do we do this, why we name things. The words and actions are not separated, they're interdependent. If we separate them, they're just slogans. They're just activism and populism. Oh, this is what I do, this is what I wanna do. But what Paulo Freire reminds us is they're interconnected. The word and the reflection are connected in order to name the world and to transform the world that we want to transform. And I believe this is what you're doing here today. You're naming the world in order to transform it. I will, however, in this presentation, I would like to expand on that maxim of Paulo Freire and emphasize how our results can be achieved and how the quality of the outcomes that we want can be improved when we bring humanism into our classroom, into our practice. So leaders, we all come in different shapes and different forms and different sizes. So sometimes we understand leadership with capital L, sometimes leadership with lowercase l. For example, when I was here in these classrooms, I was a leader, if only of myself. But the truth is, I always consciously or unconsciously gravitated towards leadership roles. I never taught a course. Nobody told me how to do it, but I have mentors. I have role models that taught me how to lead others. They push me, Many times they push me and say, you gotta do this, you can do this. They open the doors, and they made me believe in my capabilities, in my abilities to do things. And they believe in me when many others did not. Because although I'm here sitting, very happy with my career, there were many doors that did not open when I knock. So we all have the potential to flourish. We have the potential to become beautiful flowers and beautiful old trees only if we are well grounded, if the soil that we stand on is fertile and nourishing. And of course, you know who I'm thinking about, Cameron Jones Gardener's Tale. And now, 33 years after I started my graduate education here, I assume and embrace my positions and try to be conscious of the roles as a leader that I have. I don't have an imposter syndrome, and I try to exercise them in a very mindful manner. So, but if we really want to be leaders in health equity, if we want to create the change in our major social determinants of health, like racism, capitalism, and patriarchy, we must start at home, right here, in our institutions of higher education and research. I argue that we need leadership based on humanism, rather known as a humanistic leadership. And this approach, I'm going to explain very briefly what I mean by this. This approach emphasizes the intrinsic value and potential and dignity of us as individuals in an organizational context. After all, we are in an organization. In simple terms, to be humanistic is to treat people not as a mere resource, but rather as whole human beings, the whole persons with emotions, with experience, with a past, and with aspirations. Humanistic leadership involves guiding and influencing others with an emphasis in developing their personal and professional capacities, but also our ethical behavior and our well-being. This leadership style, of course, implies participatory and inclusive process in our decision-making. In essence, leadership based on humanistic principles demands our attention to social exclusion process. We must embrace anti-racism, diversity, equity, and inclusion in our classrooms, in our research, in our community engagement, and in the administration of our schools and programs of public health. And at the risk of this becoming a lecture that you sign up for, humanism, and by extension, humanistic leadership, is grounded in several philosophical principles, as many of you probably know, that emphasize our agency and our dignity. None of these concepts are new, of course, and they have changed and evolved over the classical, Renaissance, and modern interpretations that tell us, how to be a humanistic person or a humanistic leader. But I would like to take a few minutes of us to focus on each of them as food for thought. Well, let me start with individual dignity and worth. Of course, as advertised, this principle asserts that every single of us deserves respect and consideration. In leadership, in humanistic environments and practices, foster individuality of the team members, recognizing their contributions and enhancing their own development. In our work, we are referring to each of us as team members, but members of a whole, each of us with very exceptional contributions. Next, we have autonomy and self-determination. Philosophically, of course, this is rooted in the belief that we, as individuals, can reason and we can make decisions. In leadership context, this means creating environments where students, faculty, and staff are empowered, as Ella was reminding us earlier, to make decisions, to contribute to problem solving, and to have control over our work. Next, we have rationality and reason. And of course, humanism is a child of the Enlightenment, and as such, it underscores the importance of reason as a tool for understanding the world and resolve our problems. Humanistic leaders, therefore, encourage critical thinking, evidence-based decision-making, and fostering a culture where logical analysis and creativity are valued. And last, this is my favorite one. This is when I become a preacher. We must live with our ethic principles and with our moral responsibilities. Humanistic leaders act ethically, we promote a try to defend fairness and justice, and we consider the impact of our actions as a group and organizations in the larger society. We all have our reasons to be here pursuing careers in public health. I was here for the paycheck. That's not true, right? I still am looking for more promotions. You will be surprised. My undergrad degree is in communication. And I had other dreams, not this one. But it was only until I started working with a non-for-profit organization promoting their work in health communications in the border of Mexico and Juarez, and when I was confronted with the AIDS epidemic, that I realized the consequences of social exclusion. And in public health, I found the answer, and here I am. So, our work and our actions must be guided by our public health needs. Not the profit sharing, not the market economy. We define the purpose and the vision of our career and what public health means. And I believe I'm safe in saying this in my bet, that this is why you all here. Students, faculty, community members, and leaders. You all have chosen this field because you have made a commitment, you have a moral responsibility, you have ethical principles that are guiding you to this career. Like I say, I standing here, being here absolutely takes me back to my early 20s. Even the ride from the airport to here is like, oh, that was here, many years ago. I was wondering about the airfare tickets. It was like probably $250 from here to El Paso back in the day. But I was full, of course, with aspirations, with enthusiasms, with many goals of what a career in public health would look like for me. And spoiler alert, I was not very much off. This is a wonderful career. You all have wonderful impact and great things to do ahead of you. Michigan prepared me very well for the roles I will go on to hold, starting from, remember, I was an RA assistant, a research assistant for Mark Zimmerman, all the way to my current role at University of California, San Francisco. But I'm sad to say that in my career, I also have come in contact with people who do not believe humanism has a place in our work or in our careers. At minimum, they slow us down in our advances towards health equity. Academia itself is very adept in enabling individual contributors, focus only on the research, on the work, with no time, no interest in the work of departments, communities, and colleagues. But we celebrate our department's vision today of laddering up to something much more vital and important, which is health equity. The department new leadership under Dr. Hudson and the support of our Dean Bowman suggests to me this keen awareness of the interdependence of humanism and health equity, lining them up together. But at the end of the day, it's up to you. You decide what you stand for, what you believe, and if all of this is good enough for you to pursue a career and to pursue our mission of ending health inequities. As you form your own personal and professional selves, I invite you to consider a few things I believe are critical for us to live into our new department's name. And I'll start with personal growth and fulfillment. Of course, there are elements of our careers and scholarship that we prefer not to have to deal with, like management administration, biostatistics, and you know what I'm talking about. But I hope that that work is in the minority and that you find much more aspects that are challenging to you, that engaging and solving for those interests and fulfills you to your desire to learn and continue growing. Try to stay connected to the why you are here, what drew you to this work, and rush to it into a new and unknown elements, because there will be many unknown elements. Explore these with your friends, with your professors, with your mentors. Have conversations about how we have gotten through, and it's a very difficult, tough environment. How do we remain on the watch for egoism, burnout, and more importantly, how we move through it with greater personal growth. Next, interconnectedness and community. We are constantly walking this fine line between the individual and the collective, or seeking the collective as made up of individuals, and how sometimes community organizing is the best approach to create social change and achieve certain health outcomes. As I referred to earlier, community organizing was one of the forces that brought me here to Ann Arbor and led me to this school. In this classroom and in these halls, I began to understand and strike a balance between the collective and individual, first in my learning, looking for opportunities to collaborate with others, to seek thoughts and approaches from my peers, my professors, and my mentors. If we practice interconnectedness and community here, it will be almost a second nature to us in our professional lives. And to achieve health equity, which is a great challenge, it can only be achieved in collaboration. There's no way around. And then I want to bring your attention to appreciate the human creativity and potential. Like many professions in our field, in a particular field, change is constant. While we have still great challenges such as obesity, maternal health, and vaccination, who would have thought us we'll be fighting this war again, are too familiar. We have so many tools in our toolbox, many of them to address these issues. So bring yourselves to bear in your scholarship and your thinking. Let your creativity loose, think freely, and really think big. Yes, the past and history offer us great lessons and context about many interventions that worked then. Many of them still work. But can we make them more effective, more inclusive? Can the quality of the outcomes be improved with ingenuity and when diverse voices and perspectives are sought and welcome? In my humble opinion, or IMHO, as my son will text me, public health can take a page from the private sector and elevate and prioritize innovation. And maybe I have been indoctrinated over in the Bay Area, but what if public health becomes like a startup? What if we work like small startups? Maybe we can do things a little different. I try to keep these principles on top of my mind in my leadership roles. And I'm sharing it with you today in the hopes that students, faculty, and administration see all these as possibilities of embracing, that we can embrace in our work so that we building a longer future. But there's always a but, right? Leaning into humanistic principles is not always easy. It's never been easy. Long-held beliefs and traditions about the ways we should be, the ways we're supposed to teach, the ways the students learn, all can work against this. Just as I'm suggesting here, there is an ideal of how we can lead ourselves and lead others, I also encourage us to be on the lookout for the foes of humanism. Among them, right now for me, is lack of authenticity. Many cultures suggest to us that they value authenticity, knowing what they stand for, and therefore knowing how we must show up. This field, our field of public health, is static, is destined to stay static, growing irrelevant in light of the realities of health inequities if we do not first embrace people and ourselves in our authentic selves, with emotions, experiences, and aspirations. Of course, the pursuit of public health has made great technological, biomedical, and scientific advances, but they should not come at the expense of our humanity, our authenticity. We cannot achieve health equity if we do not allow people to be who they are and encourage them to think, but also to be guided by their instincts. I will quickly follow here with the fact that we in public health have an equity problem ourselves, right? Consider the diversity of populations that we serve around the globe in the country. Then look at the diversity of students pursuing careers in public health. and then take a hard, long look at who's running the shop. Research shows that we still have issues, we are still systematically excluding faculty of color from faculty and leadership roles. As an example, in 2022, in departments like us around the country, 67% of the full professors, just full professors, were white, 9% black, almost about 10% Latinx, 0.7% American Indian, and 6% Asian American. Of course, the numbers are worse because this data comes only from schools and programs that are associated with the Association of Schools and Programs in Public Health. The programs are larger than this sample. So why do we need a diverse faculty and leadership body? The obvious question, but I should address it. It's our moral obligation. Why do we keep excluding people from jobs? Why do we keep excluding people from pursuing their dreams the way we do? And of course, we know who's the most affected by health inequities, right? People of color, working class, and poor people. They're close to the problem, and they are very close to the solution. And of course, diversity always improves our learning, our research, and our leadership skills. But then how do we go about reducing or addressing racism in recruitment and retention of faculty in our schools and programs of public health? So now we don't have affirmative action like we had it, right? Let's assume we had it. We don't have it anymore. So how do we do this? We must hold ourselves accountable, and I'm talking two bodies primarily, and I want you to remember this because you will meet them. CEF, the Council on Education for Public Health. Second, the American Association of Schools of Public Health. Hold them accountable about who's running the shop. And of course, we have to make commitments here, and it has to come from the top of the food chain, if you will. Presidents, deans, chairs of departments, they can set goals. They can set resources aside. They can tell us you must recruit this particular type of faculty. That's how I'm here. Because a dean told their faculty, you must bring a brown person, a Latino person. That was it. There was no way to do it. And she was able to do it, and then I'm here. So I will be remiss here to suggest that it's only people that gets on our way for health equity and addressing and building humanistic principles in our leadership. But it's also the model, right? The university as we know it is a very ancient institution, wonderful in so many ways. I love it, don't take me wrong. I'm primarily an academic. And every society needs these intellectual spaces, but the model is dated. Right? The model has not changed at the same pace of other societal institutions, and the change has not been led by us. So I don't have the answers, of course, but I do have questions. What are we teaching? What's our curriculum like? The question I want us all to keep asking is, does our education reflect our current problems? Does the curriculum address our context and the issues of our time? Are we just teaching the formal mechanics of public health without a creative force, without a curious and critical eye? Are we just reciting recipes? I'm going to come back again to Paulo Freire. Are we treating students as empty bases to be filled with data? Are we working with them as co-learners, as creative and critical minds? Are we filling our time in the classroom with PowerPoints? Let me repeat again. Are we filling our time in the classroom with PowerPoints? Or are we engaging in dialogue and critical reflection? Are we engaging in active learning? It is time to have this discussion and these conversations. It should be led by those who will take us into the future. And it will be wonderful if it starts in Michigan. So today, as we take ownership of the new approach of human health behavior by giving equal billing to our goal for health equity, I'm suggesting one way we can live into this aspiration is by incorporating, embracing humanism in public health. I work actively with my teams around the country, in particular UCSF, who pays my bills, to foster these principles of humanism, primarily collaboration. We humans desire connection, yet our ability to be effectively working together, we don't do it very well. It's one of the most challenging endeavors that we have. Egoism, lack of trust, fear, resistance to change, let alone gender, racial, class system, all of them and our reward system get on the way. That's not to say that we are not, that our learning, our research, and our public health practice doesn't involve working in teams and in small groups. It does. But we don't devote enough time to learn how to do it. We just thrown into that arena, right? We don't have the time to reflect on how we do it. And teamwork can play a very crucial role in a very micro but important way in reducing biases such as racism and sexism, because it can foster inclusive environments and promote understanding and respect. It can and it should start here at home. Let's not perpetuate in our classrooms, in our work, the systems we're trying to overcome. Let's build diverse groups from the ground up, and from the ground up, learn how inequities are being fought. All right, one day, one of you will be standing right here. I assure you. So what story do you want to tell? More than 30 years into your career in public health, what memories do you want to share with those who will follow you? The success you will hopefully be looking back on comes from the decisions you're making today. In these classrooms, you're developing the foundations and you're receiving one of the best educations around the country in public health. I invite you all to keep the reasons you have chosen public health as your career close to your hearts, but your hearts close to your mind too. Keep dreaming, continue being so creative, dreaming new things and new ways of doing public health, and foster your own individuality and honor the individuality of each of us. Create communities in your classroom, your study groups, in this department, in this school, with the goal of cultivating the capacity to grow as individuals in solidarity with others, not on ourselves and by ourselves, because that's how we're going to change this world. So I submit this. This is how you can look back, as I do today, on our practice and scholarship at Michigan with great gratitude. Thank you. Okay, now, can you hear me this one? So now, I can do it. I can do it. So I have the mic and I have the space, so I'm going to take over. You gave me the microphone. No, really, because I want to engage in dialogue. I really, and to start, I want to take the priority of asking the first question. How does humanism look like? Does it resonate to you? Is humanism leadership aligned with our ideas of fighting anti-colonialism and anti-racism in our field? That was not rhetorical, like Darren was saying. This is the first question.
Well, first of all, I appreciate your talk, and also love Paulo Freire, teach a class where I use critical pedagogy, so totally aligned. I love that because I think that at the end of the day, what we are doing is working with humans, and I think sometimes humans become numbers, and then they don't become human again. And so I like the humanistic approach, and I think that it really, to me too, I mean, it speaks to who we are as humans. You know, we come into this space to do this work for a reason. You know, we chose not to go into business or politics, well, some politics, but other things. But we do this because we care and we want to make a difference in the world. And so I think tapping into our humanity and sharing that with others is the right way to go. So I agree with 100%.
What what reflects to me when, as you were talking, is the very first group of alumni who spoke about relationships and the importance of relationships and why we get into this business in the first place is because of people. You were, spoke to that exactly. And to me, humanism is the operationalization of that in our work. So that's how what made me reflect on what you were saying.
I actually think about what Ella was talking about this morning and about this idea of the resistance of her being the president of APHA because she didn't have a degree. And for me, doing this work is really about tearing down these walls and divisions that we've created, in many ways because we think that a degree means that we understand this work. And for me, it's really important to seed power and to make sure we are sharing power and shifting power to communities. And just piggybacking Gary, right? Yeah, I've heard a lot about you there. So. He was saying that, I forgot what you said then when I was like, oh yeah, it's scary. But either way, it's really important for us to understand that we're not working with numbers. We're not working with words. We're working with people. They're giving us blood. They're giving us stories. They're giving us pain. They're giving us love. And when we forget that, and we forget the value of what that is as a learning opportunity, I think we just miss the mark. So to me, it starts with us in this room, ceding power, giving up power and saying, who cares if I have a degree? Because you're the one that's doing the work. You're the one that's living the life. So you're the expert. How can I help you? Rather than let me come up with this theory that really may not even be speaking to the experience and the real life experiences and solutions that they're already implementing.
Thank you. That was really good, I think. I've also been thinking of kind of what you alluded to in your talk about how, as important as that is outside in the community, is just as important inside of the classroom as well. And acknowledging that students come in with so many different perspectives and experiences, and we talk so much about acknowledging community perspectives and what they bring. There's members of those communities that are in the classroom as well, and a wide variety of experiences. And so it's important to value those students, what they bring to the classroom, and that the perspective that we are giving as we're teaching these theories and these frameworks may come from a white-centered view, and understanding how to kind of shift that and allow room for more perspectives in the classroom as well.
I think I got it. Okay. Yeah, I just want to echo what everyone is saying. So I think the words really resonated with me, like this humanistic approach and how are we every day kind of battling anti-colonialism and white supremacy and with these themes of race, power, and privilege. And so I have the tremendous privilege of being a community organizer, and that was my job before coming into the program. And I work with youth in Southwest Detroit, and I am from Southwest Detroit. So the program that I manage is a program that I went through in my community, and so I have the immense privilege of also having an educational background and having access to academia, higher academia. So now I'm in my master's program in HBHE. One of the reasons why I applied to the program was because of the name change to equity, because that is the center of my work, and that is what I teach my youth about. I teach them about equity, I teach them about how we are humans first, and how there are all these forces that are working against us every single day. And what can we do to battle that, right, in our everyday lives and with the knowledge that we have? And so I talk a lot about how knowledge is empowerment, and knowing your history and knowing your background, knowing like the things that happened in the city, because I'm from Detroit. So it's like understanding like the history of the city and how that impacts us today is like very empowering, and it almost like reminds us of the people that worked to get us to where we are now. And it's this very humanistic, it humanizes the struggle, you know? And so I think a lot about that when I'm in my classrooms, and I think I have a big privilege to be from a historically marginalized group, and then being in these spaces to also bring my perspective and my experience is kind of what you mentioned. You know, there are people in the classrooms that have gone through struggle and continue to, and we are firsthand like living the inequities of the world. And it's a big privilege to be able to come to a higher institution and address these things and talk with peers and tell them firsthand what it's like to go through these things. And I say that because I understand that in an institution like this, there are people who might not have been exposed to the things that I have, right? So yeah, I think it's very important to humanize and to remember the people who are on the ground, and to remember the leaders that are being developed as well at the community level. And remember ultimately like who these policies are going to be impacting, what our work is going to be impacting. So I have a big privilege to be able to see it firsthand, and then be able to be here and yeah, connect the two.
Do we have time for one more comment? Okay. I really appreciate you bringing the discussion of humanism into this space. It's something I think a lot about. And I want to read this quote actually from Eber Hampton, who's an Indigenous researcher and scholar. And I love these words on it, if it's okay if I share them. But so he says, "One thing I wish to say about research is that there is a motive. I believe the reason is emotional because we feel. We feel because we are hungry, cold, afraid, brave, loving, or hateful. We do what we do for reasons, emotional reasons. That is the engine that drives us. Life feels. Feeling is connected to our intellect, and we ignore, hide from, disguise, and suppress that feeling at our peril and at the peril of those around us. Emotionless, passionless, abstract intellectual research is a gosh darn lie. It does not exist. It is a lie to ourselves and a lie to other people. Humans, thinking, living, breathing, feeling, living, breathing, thinking humans do research. When we try to cut ourselves off at the neck and present an objectivity that does not exist in the human world, we become dangerous to ourselves first and then to the people around us." And so I love those words, and I really appreciate you bringing more of that discussion in here. Just wanted to share that.
Any last thoughts or questions? Well, thank you. Why don't we give our keynote speaker a round of applause? And next, we'll hear from our esteemed Dean Bowman.
So how's everybody doing? Good, good. It's a pleasure to be here. The sight of the room does me a lot of good for the occasion. What a wonderful speaker we just heard from. So let's give another round of applause to Jesus. I want to thank all of you for just contributing to what a wonderful day. And I feel like I've grown just being able to listen to the last keynote. The concept of humanistic leadership was very thought-provoking for me. And leadership is complicated, and one of the things that I always try to do is just sort of simplify my approach to various problems, and often that anchors me to hearing my grandmother's voice. And you mentioned that you draw upon lessons from many places. Often we think of those as other leaders, professional leaders with titles. For me, it's some of that grounding and anchoring that helps me to navigate complicated situations. And then also, the other thought-provoking thing for me, as I thought about this concept of humanistic leadership, I am a leader, but thinking about a humanistic approach in a holistic manner, right? I walk into some rooms not as a leader. I walk into some rooms as just a member of the community and still taking a humanistic approach. As a father, as a husband, still taking that humanistic approach. So hopefully it wasn't only thought-provoking for me through the Q&A. I think left all of us something to go and chew on and hopefully become better, not only as individuals, but in the work that we're doing. So some time ago, I received a memo from Dr. Cleo Caldwell on behalf of her colleagues. She was then the chair of HBHE, and it was a memo written to me to request a name change for the department from HBHE to HBHE. And it's not every day that a dean changes the name of the department, so I wanted to take some time just to reflect on what are the proper channels, the approvals that are needed at the university. There's some things that we actually have to go outside the university for. But I also took time to consult and get some feedback from various stakeholders, including alumni. And in addition, and some of this was built into the case of that was embedded in the memo, but taking sort of assessment of the department and its activities to make sure that the proposal was in line with what was actually reflected in the department. And what I saw was that the proposal and the request was very much in line with the research that the department pursues. Very much in line with the courses that the department offers, very much in line with the partnerships, the long-standing partnerships that the department has fostered and continues to cultivate, very much in line with the local, national, and global service that our student, staff, and faculty and alum engage in. And so there are many really, really, really complicated decisions that I have to make. This one was an easy one. This one was an easy one. So during that time, as we were working through the various channels, Cleo retired, and I had a chance to continue working with Scott. Scott, where are you? Appreciated Scott checking in and continued advocacy as we got approvals at various stages. And so I'm so delighted to be able to make this change that really reflects, I think, the future of the field, but also it reflects many of the embedded strengths in the department. I was glad to hear of someone whose interest was drawn to the department because of the name change, and I hope that resonates with prospective students in a much clearer way, and really look forward to all of the wonderful things that the department will go on to do. Very excited also that this change comes with also a change in leadership for the department, and having Daryl. So Daryl, I really look forward to your partnership as leader of the department, but also the school, externally to the department, and all of the partnerships that are connected, and then also at a university level. And really look forward just to this next chapter in the department's storied history. And I know the department will continue to do very important and impactful work, but it's nice to see health equity really centered in the core of its mission. So with that, I want to thank all of you just for a wonderful symposium, and I'm delighted that I was able to come and join you for this part, and want to be a part of the success, so please let me know how I can help. Thank you very much.
Thank you very much for your remarks, Dean Bowman, and of course, Jesus, for gracing us with your presence and your creativity, which comes through, but I just want to underscore how creative scholar you are and a true inspiration in the field. So thanks again for joining us. Next, we're going to have lightning talks. So we'll start to transition into that in just a moment. Maybe we have time for a 5-minute bio break? Okay, so why don't we do that? We'll have a 5-minute bio break, and then we'll come back with our lightning talk session.
Alrighty, folks. Good afternoon. We're going to transition to our lightning talks now. Yes. So good afternoon, everyone. My name is Ezekiel Medina. I am an MPH student in my second year. We're going to transition to our lightning talks now. I'll be helping to moderate this session. We have 10 amazing speakers. You're seated throughout the room, so they're sitting amongst you. There's a title slide with your name. When you see that and you hear yourself being announced by one of us, please make your way down to the podium.
Hello, everyone. My name is Akila Patterson. I'll also be helping to moderate this session. Each speaker will have 5 minutes, and there will be no Q&A at the end of this session. So for all of our guests here today, we ask that if you have questions, that you join us for the reception right after to join our speakers, and then also all of our poster presenters as well. So we're very excited to see you all today.
And we are going to begin with Sade Richardson.
Okay. All right. Good afternoon, everyone. I'm Sade. I'm the Director of Strategic Initiatives in the Office of Public Health Practice and an alum of HBHE. I get to talk to you today about one of the more exciting parts of my job, being a Caribbean girl myself. How do I transition? Thank you. We can't see the slides up here, so we're gonna go. Okay, so since 2013, we have been taking students each year to Grenada, with the exception of 2019 and 2021, to work with our variety of community partners. How this partnership started was because of another alum, Dr. Rohan Jeremiah, bringing the idea to our office, and then, of course, our school being supportive of our efforts. So with this partnership, we really did rely a lot on our partners in Grenada. So we've worked with nonprofit organizations, governmental organizations, as well as occasionally some for-profit organizations to do different public health projects. And of course, from the school, we really depend on the generosity of our donors being funded with these projects, and of course, students being interested in doing this work. So what exactly does this look like? To get to Grenada, the students actually apply and go through a process to get into the courses. We take about 12 students, and we have like 70 apply each year. It's really hard to narrow it down and choose the students that go, but the students that go work on interdisciplinary teams across different projects. They also work under the Public Health Action Support Team, or FAST, which is another thing through our office. FAST has been around since 2005, and the goal is to really get students to apply what they're learning in the classroom into the field of public health and see what practical public health looks like across different teams. If you didn't know, Grenada should not be confused with Grenada, which is in Spain. Grenada is a Caribbean island. It's located in the Eastern Caribbean. It's the Spice Isle. The population is about 124,000 people, so it's relatively small, and they just celebrated their 50th year of independence this year. Fundamental to our approach is really looking and using principles of CBPR. So our community partners drive the process. They decide what we're working on. They let us know what their priorities are, and oftentimes the projects tend to build off of each other. And what I think is really cool is at the end of the week, the students present on that Friday what they were working on in that week, their preliminary findings, and then come back and do a report. So these are some examples of some past projects. As you'll notice with the Grenada Red Cross Society, we've done a lot of things with them. We started off working on a SWOT analysis, which built and led to a model of engagement where we were looking at, well, how does the community perceive Red Cross? This led to us creating a volunteer policy because that organization is heavily dependent on volunteers. They do not have any full-time staff, and they needed a way to assess what the volunteers were doing. This past year, we had students work on setting up a voluntary blood donation system. So right now, the model is family members typically go donate as needed. So they're trying to assess, well, what are the ways we could get people into voluntarily coming to donate blood? With the Ministry of Social and Community Development, Housing and Gender Affairs, this year we worked on doing key informant interviews and focus groups as they're trying to set up a disability affairs unit as a unit within the ministry. So they wanted to really understand, what is the disability landscape like on the island? If you've never been to Grenada, it is extremely hilly. It's very hard to maneuver with physical disabilities, so it was an opportunity for the community to be heard. We've also in the past worked on developing an infection control protocol that's actually being used in the homes on the island. I think it's really cool that we've worked with the Ministry of Education as well, and in 2016 we developed a national policy on alcohol and drugs that was adapted on the island. So this coming year for 2025, we'll be working to make changes with that. Lastly, Grenada Planned Parenthood, I myself as a student, I was able to go and work on that project myself and then take students back to continue the work I did as a student. We're looking forward to expanding our ways of engaging. They're really looking at opportunities where they can come here. They even had the idea of having a satellite office for us on the island, so we're really embedded within the community. We're working on establishing MOUs, and for students, if you're a first year looking for an internship, look out for my emails because we're starting a formalized internship process where you can apply and go do your internships in Grenada for 8 weeks. That is my time. If you have any questions, feel free to reach out. Thank you.
As you can see, we move. Awesome. Next, we have Gary Harper.
Now, people are talking about a bunch of green arrows. I see 3. The big one. Oh, yeah, it's right there in front of my face, right? Yeah, that's me. So my name's Gary Harper. I'm faculty in HBHE, and I'm going to be talking. I'm used to having things right here, so just everyone knows, we're looking up there. About work we've been doing for about the past 15 years in Kenya. So the title is All Put Together, which is Harambee in Swahili, which is very important in Kenya. Promoting health equity for gay and bisexual young men is in Western Kenya. It's a picture of a bunch of us. Reve's in there, Laura's in there, some of our former students, and just acknowledging everyone who is there. I also want to acknowledge my parents, for whom, without them, I would never be here. So I want to honor them. So gay and bisexual men in Kenya, it's a rough place to be gay. It is criminalized. You can get up to 14 years of prison. It's really the sex acts that are criminalized, but the police and other structural systems use it as a way to abuse gay and bi men and women as well. There's high levels of stigma within multiple systems. So a lot of times there's lack of education, lack of health care. Even when you go in for health care, we hear stories over and over again about being beaten by healthcare workers when they find out that you're gay. So for the past 15 years, we've been working together with community-based organizations. What I'm going to talk about is really not about what we did, but about ways in which we've tried to support the young men from the community, and we're going to end with their stories. Unfortunately, they couldn't come here, but in my quick 5 minutes, we have some pictures and information that they wanted to share. Some of the core elements of when we're working with research projects, we always make sure that we're building infrastructure within the community, within organizations, and with individuals. And so we have 4 C's we focus on: competence and a range of skills. It's not just what's needed for the project, but what's needed for life. Also confidence in their abilities. A lot of times there's a lot of intimidation working with university folks or other folks in the government, and so we really help to build that self-confidence. Connections with key stakeholders, both in the US and in Kenya, and then careers and jobs. And we talked about this earlier with the trans women too. Without a job, you can't have health equity. And so we really focus a lot on making sure that the guys that work with us are funded and get jobs after as well. These are a bunch of logos of a lot of the projects we've done. So some of the things that we do as a team is we make sure that everyone's hired as an employee of a local organization, so they're not just given a stipend or a pizza party. They all learn research skills, so quant, qual, mixed methods. Some of our guys could probably run laps around a lot of folks here. Job skills, so again, we want them to be employable after they've worked with our projects. Also formalized education. So we've supported the education of several people. Several people on our team have helped to pay tuition, helped them to get into different educational programs. Communication and counseling skills so that they can deal with conflict, but also deal with some of the structural heterosexism and violence that they deal with. Also organization, networking, organization and development skills. So we want to build the infrastructure within community-based organizations to be able to be sustainable. Instead of just like funding projects, we work on using elements from organization design and development to really build the infrastructure. Collaborative development of tailored health promotion materials. I actually do that through an undergrad class that I teach. So our undergrads are paired with different LGBT organizations in Kenya, and throughout the whole semester, they work on the development of health promotion materials that are designed specifically for the communities that they work in and for the health issues that they're concerned about. And then preparation to receive NIH funding. So one of our partners, we were able to help them get a federal-wide assurance number with NIH so that they can get, whoa, 1 minute. All right. Well, we'll hear from the guys. I'm going to talk really fast. This is Felix. He's actually a counseling psychologist. He's one that we were able to support through education, research. He said, I've gained vast knowledge and skills through training in mental health related information, HIV interventions, quantitative research, manuscript writing, co-author, that's the other thing. Their CVs look better than a lot of folks. That's provided me with job opportunity, also strengthening my personal development, networking and collaboration, fosters a sense of ownership and empowerment, the development of health promotion materials, which were essential to particular areas of local culture and context, has led to more feasible and appropriate community solutions. Because it's their voice, it's everything about them. This is Edwin, identifies as a gay researcher, also mental health and wellness advocate. Reve's been working with him a lot and supporting his education to get his degree. Also the founder of Nafasi Innovations, which is a nonprofit organization, and my time is up. So I'll let you read that one. And then Ellie is our last one. He's been coordinating. I've worked with Ellie for 15, 20 years now and has seen just a tremendous growth in becoming a real leader in the community. All right, thank you. Sorry for going over.
Thank you. Okay, now we have Hannah Rice and Irving Suarez.
Big arrow?
Big arrow.
Big arrow.
Big green, but
All right, hi everybody. My name is Hannah Rice, and I am a second-year MPH student in HBH Equity.
And my name is Irving Suarez. I am also second-year HBHE student. So I'm going to take a second here to let the image run through its course. I'll let you guys get familiar with it. Today's presentation is called Ice in the Heartland, utilizing an art-based curriculum to disseminate information into middle school and high school classrooms. Go ahead. So a bit of background on the project. When we use ICE, we're referring to U.S. Immigration and Customs Enforcement. Now, as a whole, the project considers the impacts that worksite rates have on the Latina communities around the country. And in 2018, Dr. Bill Lopez and his research team at the time conducted 76 interviews with community members from 6 different communities that were impacted by these rates in 2018. Now, these rates were largely unannounced, violent, and very much targeted to the Latina community working in agricultural sites, manufacturing sites. But then after these interviews were conducted, there was a collaboration with Dr. Darren Stockdale from the School of Education, and a high school and middle school curriculum was developed to be able to teach these students about these impacts. A key component of this curriculum is that it's art-based, which includes an art gallery that was developed by Dalia Harris and Carolina Jones. Now, this past winter term, Hannah and I had the opportunity to go to 3 schools, 2 high schools, 1 middle school. We worked with 9 different teachers for a total of 458 students being exposed to this curriculum.
So before we went into the classrooms, we got together and conducted sort of a focus group and workshop with participating teachers to get an idea of what it would look like for us to bring this art gallery to their classrooms, how they would like to incorporate it into their pre-existing curriculums, where it might fit in. We worked with a fantastic group of teachers. They were super engaged and really incredible. And once we had a good plan of how it would work for each of their classrooms, and that was customizable, we went to schools, we set up galleries in classrooms, and gave students about 20 and 30 to 30 minutes to walk around, take a look at the artwork, and they had with them a worksheet that was structured to what we called like a See, Think, Wonder type of activity. So questions asking them to reflect on what they were seeing, what it was making them think about, questions that were coming to mind, what it made them wonder, what they wanted to know more about. And something that we did intentionally is we did not give students the titles of the artwork, nor did we give them the artist statements that accompanied them. We hoped that this would kind of encourage students to really imagine and think about what the artwork was saying to them rather than reading the statements first. And then after we left in the next class period, teachers reviewed the titles and artist statements with the class and created classroom discussions based on what they learned and what they took away from the project.
So some of the initial themes from students, we kind of learned that familiarity with immigration rates was wide-ranging amongst students. But some of the first ones include trauma and fear. A student from Pioneer High School says, the fear and anxiety of being indefinitely separated physically and emotionally from their loved one is hard to cope with. Next one. Another theme is impact on families and communities. Ice in the Heartland shows that before the ice came and separated and took families away from their homes, they were once very happy and were peaceful before the bad things happened. And lastly, critique of immigration policy. Ice in the Heartland helps create more empathy because you can see everything they have to go through, and it makes you want to help them out and fix these immigration policies. And now, as a communication method, the art kind of helped humanize this issue, kind of bridging the gap between these abstract statistics and these individuals' lived experience, the human experience that we kind of talked about.
And so some of our next steps, so we got an incredible amount of feedback from students and teachers that participated in this pilot-ish program, and so we're hoping to update the curriculum based on the feedback we received. We're also hoping to publish an accessible online version of the curriculum so it can be used in other classrooms. We would like to submit an academic, like a peer-reviewed article on our work and generally about art-based public health curricula, and eventually return to teachers in Tennessee, which were one of the sites that took part in the initial interviews, and share the work. This QR code here actually takes you to a copy of the activity we did with students. You can access it in English or Spanish. If you want to go through it yourself, take a look at some of the artwork and say what you see, think, and wonder. So thank you so much.
Great, thank you. Next, we will be hearing from Hurley Riley. Great.
Hello, everyone. My name is Hurley Riley, and today I'll be presenting on Trauma-Informed Programs and Practices for Schools, or TIPS, which is a multi-level framework to promote health equity in schools. And this work is led by Dr. Alice Miller and Dr. Todd Herrenkahl. So first I'm going to talk a little bit about adverse childhood experiences, or ACEs, which are potentially traumatic events, and unfortunately over 60% of children in the US experience at least one ACE before adulthood. So health inequity, this is the concept that different social conditions can contribute to differences in health outcomes. We know that ACEs are unequally distributed in the population, so unfortunately ACEs can underlie many of the health inequities that we see today. So here we see that ACEs are associated with a range of poor health outcomes such as heart disease, stroke, asthma, et cetera. And then also experiences such as racism and poverty are also associated with ACEs and poor health outcomes. So these experiences can also be traumatic, and they shouldn't be overlooked when considering trauma. Thus, health inequities will continue to persist unless we create environments where all people, starting in childhood, can achieve optimal health despite their trauma. So we can begin to address trauma in schools. Schools are a key context that can help reduce health inequities by establishing environments that promote healing and resilience among students. So school can be a challenging environment for students with trauma. They might experience things like withdrawal from others, decreased attention, and difficulty trusting others. However, trauma-informed schools can provide the care, support, and resources that children really need to heal and thrive. So the Trauma-Informed Programs and Practices for Schools, or TIPS framework, is an evidence-based framework that can help schools become trauma-informed. It's systems focused, so it promotes a trauma-informed equity lens throughout the entire school. It's based on 10 core pillars for establishing a safe, nurturing, and inclusive environment. It's highly collaborative. The 10 pillars are really broad, so they can be tailored to the local culture and the local context of the school, and it can also complement existing programs. So here are the 10 core pillars of TIPS. So when schools, when they align their policies and their practices with these 10 pillars, they can become trauma-informed. I don't have enough time to read them all, but I'll just read a few. So tip 3, increase awareness of biases and stereotypes in the school. Number 4, build a strong school community. Tip 6, reduce punitive discipline. Tip 10, create a support system to address emergent needs. So now I'm going to talk about some of the work we've done with the TIPS framework. So first, we conducted needs assessments. So we interviewed school professionals such as teachers, school social workers, et cetera, just to find out the extent to which their schools are trauma-informed. So here are some quotes from school professionals. So this person right here said, "I think we need more tools. We talk and talk and talk. We do book studies. We watch a video and stuff and professional development. But actually having tools that help us implement these strategies, that's what we need all the time." So we decided to create training materials to show schools how to implement the TIPS. So we have short videos that give an overview of trauma and the TIPS framework. We created a program guide, so we worked with innovation partnerships and office here at U of M who helped us bring these materials to market. We created a casebook so school professionals can practice these trauma-informed strategies. We've held trainings and workshops with different schools and districts around the state. And we've also partnered closely with the Michigan School Health Coordinators Association, or MISHCA, and they've held trainings as well. So some of our evaluation data shows that school professionals really feel more confident in their ability to apply the TIPS after they've taken the trainings. We've also worked with the Office of Continuing Education at the School of Social Work to develop these online modules about TIPS. So these modules contain videos, activities, and resources around TIPS. We did user testing to evaluate these modules, and generally people said these videos were pretty helpful and they were pretty easy to follow. Here's some of the qualitative data from our evaluation. So people were eager to utilize the content after they took the modules. So this person said it was a game changer. Participants also suggested some additional content that we want to incorporate into the TIPS modules in future versions. So next steps, we're continuing to develop materials that schools have expressed a need for. So we're developing a TIPS implementation guide, a staff well-being guide, and then TIPS resources for early childhood, so we can really reach children early in development, even before the K-12 settings. We're also continuing our work with MISHCA and different schools and districts in Michigan to help them become trauma-informed. And then, of course, we continue to collect evaluation data. So lastly, I just want to leave you with this message. Trauma-informed schools can promote health equity by creating safe, nurturing, and inclusive environments where students can rebound from adversity and trauma. If you want to learn more, please visit tipsforschools.org. Thanks.
Thank you, Hurley. Next, we have Iniabasi Ubong.
We said the big green button, yes?
Yes. Big green.
Him, okay. All right, cool. Hey everyone, good afternoon. I'm Iniabasi Ubong, and I'm representing the Resilience and Resistance Collective and presenting on behalf of New Wave Brotherhood. And so everything I'm sharing today is the result of like a huge team effort. My other authors are Ramonte Parker, Elliot Evan Popoff, Michael Price, and Gary Harper. And I'd like to start off with this quote because it's kind of emblematic of what we found out when we did community forums with Black transgender men and Black trans masked people in Detroit. Even when I speak up, even when people misgender me, I will speak up for myself. And I'll just add that while I am Black and trans masculine, I'm not from Detroit, I'm from like outside of Flint. And so just for background, we already know that trans and non-binary people in the US experience stigma and discrimination. That's been evident, made evident by the number of anti-trans bills in recent legislature. There's also not a lot of community-engaged research designed for, with, and by Black transgender men, and even less research in general on Black transgender people. And so I want to take y'all to our community academic partnership. So New Wave Brotherhood was created in 2019 to meet a need in the community for a safe and welcoming space for transgender men and other transmasculine folks. The organization has been providing clothes, emergency assistance, community building, and other social events. And so in 2019, New Wave and the RRC, the Resilience and Resistance Collective, discussed the need for more funding and more capacity building. And so out of those conversations, and as a collective, we applied for and received a small planning grant. And to that end, in the summer of 2019, we conducted 3 community forums with transgender men and transmasculine people. We had 17 participants in total between the ages of 18 and 35. And so there were really 4 overarching themes that came out of that research. Strengths and resiliences, challenges that the community is facing, health needs, and program recommendations. And so I really like this first quote, "Nobody is gonna stop me from being me." There's a lot of strength in that community, and some of the ones we heard about in those community forums were just like feeling comfortable with yourself, having a unique gender perspective, and working on self-healing and self-acceptance. There were lots of community strengths too, and people talked about wanting to mentor, wanting to teach cis people about Black trans masc life as well. There were also lots of challenges. There were lots of comments about being perceived as a threat, being more vulnerable to police violence, and you can see that in the quote over here. It says, "Vulnerability to police brutality is not the same for all trans folks. It definitely depends on race." There were lots of comments about navigating masculinity and around the idea that in some spaces being a man means being hypermasculine, having no feelings. There was a lot of discussion about racism within the LGBT community and a lack of social support in general. There were a number of health needs that were identified, specifically dealing with depression, suicidal ideation, anxiety. There was a large discussion around trans men and transmasculine people not getting enough post-op care after gender-affirming surgeries, and not a lot of info on safer sex, on HIV, on PrEP for trans men as well. There were a few programming needs that were identified too. Assistance with legal concerns. Y'all heard a little bit about the legal project through the Love Her Collective earlier, and we always have to say thank you to the Black trans women who inspire our projects and work with us. And of course, we have a lot of the same concerns too. People wanted transition-related programming, some mental health support groups. Mentorship again came up, and finding assistance with housing and transportation. And really, in conclusion, there are complex interlocking systems of oppression that create health inequities for Black trans men and Black trans masculine people in Detroit. In spite of that, Black trans men and masculine people are creating networks of support without institutional support. And it's important that Black trans men and trans masculine people are leading and guiding their own research related to their lives and health. As researchers, we should be partnering with them and not leading those efforts ourselves. Thanks, everyone. And I'm leaving, but we've done a lot since then. You can take a look and email me if you have more questions. Thanks.
Awesome. Great. And next we have Justin Heinze.
Big green button. Hi, folks. This has been a good day. It's been a full day, but it's a good day. My name's Justin. I'm going to start with a little bit of a story. Back in 2019, Dean Bowman came to the faculty with a challenge. And the challenge was, I want you to identify problems that are facing, national problems that are facing the public health challenges. And if you can identify some challenges, the school will invest in trying to solve some of those challenges. But there was a caveat. The caveat was it can't be a challenge that's specific to a particular discipline. Rather, I want them to be the kinds of challenges that are going to require all the different units, all the different departments in public health to come together to try to find their resolution. And the faculty responded. And we responded with 4 challenges that we think are applicable to across the country. And they became the Public Health Ideas Initiatives. IDEAS stands for Interdisciplinary Discovery, Engagement, and Actions for Society. Those 4 initiatives are creating healthy and equitable cities, combating infectious diseases, building health equity, and preventing firearm injury. And I asked to come and speak to you today because 3 of those 4 initiatives are led by faculty and staff within health behavior and health education. Why I think that is so exciting is that if we are talking about problems that the entire nation is facing, this signals to me that equity needs to be part of the conversation. I don't care if your approach is epidemiological, I don't care if you're thinking about policy, if it's designing and testing interventions, if it's building partnerships, health equity concerns need to be at the table and we need to be considering them. So I have asked my colleagues to give updates on the initiatives and where they are so far. I could never do this in 5 minutes, so you can use the little scan me thing. But just starting with creating healthy and equitable cities, it is led by Dr. Metapana, who you heard from earlier today, as well as Liu Wang in biostatistics. You can see they have been very research grants productive. Congratulations. But what's exciting to me is you see these pilot grants. This is true of several of our initiatives, so it's using small seed fundings to generate partnerships to create new ideas and get them moving forward. They were instrumental in creating a healthy city tool to identify health equity gaps in cities in Michigan. And down there at the bottom, they've been inviting people both on campus and from outside of campus to come and talk about these issues, raise awareness, and engender those discussions. Next, we have preventing firearm injuries. What else can I tell you? About 45,000 Americans every year die from firearm violence. This is a new and emerging field of learning, of science, and scholarship. And folks, I kid you not, the University of Michigan is no joke leader and best in this space. Go Blue. There are so many exciting different things that are happening both within the School of Public Health and around the university. I'd be happy to talk to you about them later on today. I'll be around. But for now, I'm going to turn it over to my colleague, Dr. Neblett, who is leading the last and most recently launched initiative.
Thank you, Justin. Hey, everyone. So one quick point, our ideas is a little bit in the earlier stages, but there's one thing we want to do as we think about this work. How are the research initiatives that we go forward with informed by the priorities and needs of the community? We had an event last December in which we asked folks on campus, faculty, staff, et cetera, what things are important, and you see some of the priorities that are here. So populations and spaces where disparities arise. I'm not going to read the list, so on and so forth. A couple months later, what we did is we met with leaders in Detroit, Detroit URC board, and other folks throughout Detroit, and we said, what are the priorities that are important right now when you think of health equity? What comes to mind? Some of the things won't surprise you. They're things we heard about earlier. So air quality, people talked about the sort of expansion of truck traffic. People talked about housing, affordable housing. But we also heard concerns around disparities in cancer. One that was a direct connection with the event in December was around mental health. So a lot of folks saying we really need to do more work in that area. And then related to health service cares as a point of intervention, folks said healthcare access is a continued priority in the city of Detroit, and also health education. A lot of the residents are not really clear on how you access this information. How do we access places of care? So what we're trying to do as we build these ideas and build teams is make sure that the priorities on campus and the work that we're doing is in alignment with the needs and priorities of the communities in Detroit. Thank you.
That's it for us. There are so many ways to get involved. These are transdisciplinary issues. We would love to have students, faculty from around the school, and certainly in this department to be involved. Thank you so much for your time.
Thank you so much. We're having fun, aren't we? Okay. Now we have Paul Fleming.
All right, good afternoon, everybody.
First and foremost, I want to shout out my partners and co-conspirators on this work, Dr. Melissa Creary and Dr. Whitney Peoples, who are here in the room with us. I definitely like to think of them as honorary HBHE members because of all of the wonderful work they do around health equity. So our work is focused on a project we call Health Equity via Anti-Racist Teaching. And I want to thank Jesus for teeing up part of this because he asked, what are we teaching people in public health, right? He really challenged us to rethink what we're teaching folks. And I'm going to start with a quote from Bell Hooks, who says, "The classroom, with all its limitations, remains a location of possibility." And it's that possibility that this project tries to engage with, because the classroom is really a space of possibility for transformation, for building the future that we want. I also want to acknowledge for this work that we do, it was funded by the Poverty Solutions Initiative and also with support from Dean Bowman and the School of Public Health. So when we think about anti-racist teaching, we're not just doing it because we care about the students in our classrooms, although we do care about the students in our classrooms. But we really see, if we kind of look at this, the final box there, improved public health and reduced health inequities. So we see anti-racist teaching as a vital part of us creating more equitable and healthy communities. Because if we engage in anti-racist teaching here at the School of Public Health, that's going to lead to the anti-racist formation of students in our classroom. Those students go out into the public health workforce, and as they are making decisions about how to partner with communities, about where to invest resources, they are making decisions that are informed by an anti-racist ethos that is aiming to disrupt structural racism. And as that happens, that's when we can start to see improved public health and reduced health inequities. So that's part of the reason we think that anti-racist teaching is such an important thing that we need to invest in here at this school, but also around the country. And so one of the things that we've done to help build this work is we've created an online open course with actually the support of several folks within the school, including our instructional design team. And I want to shout out Hannah Mesa and Lindsay Thatcher and many others who have helped us create this work. So we have an online module. And really, it's all about thinking about our instructors, whether it's seasoned faculty to graduate student instructors, giving them the toolkit and training, and really the mindset that they need to engage in anti-racist teaching. And we also think about it as a journey, right? I myself, nor are my partners, fully anti-racist teachers. We are constantly on a journey to become more and more anti-racist in the work that we do. And so I want to define for us what anti-racist teaching is, and this comes from the work of Dr. Peoples, and you can read more about it in the citation at the bottom that we've published in the American Journal of Preventive Medicine. Anti-racist pedagogy recognizes the historical and contemporary role of education in establishing and maintaining racial inequities. And the key part, it seeks to disrupt and change those patterns and the outcomes they produced. And so guided by the critical relationship between reflection and informed practice, which is that idea of praxis that Jesus brought up, anti-racist pedagogy operates across three key domains of teaching: course design, in-class facilitation, and context beyond the individual classroom. So the key part here is that we're thinking about what we're doing in the classroom, but what are our partnerships, what is our activism, what is our engagement outside the classroom? Both of those are equally important when we're thinking about anti-racist teaching. I'm going to skip this next slide because you can read all about it in that article at the bottom, but again, it's Dr. Peoples' 6 principles of anti-racist teaching. Please do check them out. I just want to close by saying that with the online course that we've created, we've engaged in a pilot with University of Michigan faculty and gotten some really good feedback, and now are working towards a national rollout where different instructors across the country who teach different forms of public health can get some of this training, and it can spread across the country. And feel free to reach out to me or any of my colleagues about this work. Thank you.
Next, we have Mary Janovic.
Okay, good afternoon, everyone. I'm Mary Janovic. I'm research faculty member in the department and proud double alum of the department, even more proud since the name change. So I'm excited to talk to you today about the STEPS study. So STEPS is chronic pain self-management support delivered by community health workers to older adults in Detroit. And this is chronic pain self-management with an equity lens. We are collaborating with Henry Ford Health and other local organizational partners in Detroit. Our priority population is African American older adults. We're conducting this as a randomized controlled trial with over 400 participants. We're almost there with recruitment. Okay, so I'm gonna start by posing a question. What does transportation have to do with chronic pain? So I know in this room we could probably talk about this for the next hour. I can see people starting to make conceptual models in their heads. but let me tell you about the connection that it had for one of the participants going through our study this past summer. She worked at an elementary school about a half hour from where she lived, and she was very excited to be starting the school year soon. Excited to see the kids again, but also very stressed out because she did not yet have her commute figured out. She was not going to have a working car. The bus could not get her there at the right time, and to take an Uber or a Lyft would have been about $30 each way. So she was losing sleep over this. The stress, the lack of sleep were causing her to have a major chronic pain flare. And normally she would walk to help her low back pain, but because she was so tired, she couldn't even do that. So I'll get back to her story in a minute after I tell you a little bit more about STEPS. So we're doing STEPS because we know that African American older adults and people with economic disadvantage have more pain. And this is the result of adverse social determinants of health shaped by structural factors, including systemic racism, economic systems and policies. We know that holistic care is optimal for people with chronic pain, but unfortunately this kind of care is rare in practice, and it's especially rare in underserved communities. Part of optimal holistic care for chronic pain is teaching people how to self-manage their pain condition. And this is rooted in cognitive behavioral therapy. It includes teaching skills like gradually increasing physical activity, reframing pain, learning how to set goals, relaxation techniques, and the goal is to help people improve functioning and quality of life, even if all underlying pain can't be eliminated. What traditional chronic pain self-management does not include is attention to those social needs, like transportation, that can really make pain worse, can get in the way of managing pain. So in STEPS, this is where our community health workers come in. So we are so fortunate to have amazing community health workers. This is Mr. Mike Anderson, Ms. Leslie Grijalva with Henry Ford Health. Most of you are probably familiar with community health workers. They are frontline public health workers who are deeply embedded in communities. My favorite definition of community health workers is that they are health workers who can see and act on social issues that are often invisible to outsiders. And so Leslie and Mike do a fabulous job working with our participants. Another one of their superpowers when it comes to chronic pain management is that they are able to teach about chronic pain in a very caring, motivating, and empathetic way. In many cases, they have shared life experiences with participants. And we know that with pain care, having that positive relationship, rapport, called therapeutic alliance, is very, very important. So very quickly, Mike and Leslie meet with participants about 7 times, mostly over the phone. They help them apply skills that people learn about in short videos, work with them to set goals. Social needs screening is a very important part of STEPS. Mike and Leslie do a social needs screener right at the beginning of the program. Both Mike and Leslie know so much about the resources available in the Detroit community, so they're alert to needs that come up throughout the program. In many cases, they're able to give warm handoffs, circle back to make sure that the resource met their need. Okay, so getting back to the story of the participant, her community health worker knew about a connector service that was offered by the local bus system that could actually get her back and forth to work for only $3 each way. So that was much better. The participant's stress level went way down. She started sleeping better. Her pain subsided. With this trial, we can show that this model of pain care will be helpful for many older adults so that they can feel better and function better over the long term. So just want to acknowledge our fabulous team of student, staff, community partners, and our amazing co-investigator team. All right, thank you for listening.
Alrighty, we have Maria Barenberg and Dallas Dunn.
Hi everyone, thank you so much for joining us. I'm incredibly honored and excited to be amongst you all and share our presentation on building the public health workforce pipeline, an overview of the Michigan Future Public Health Leaders Program, or as we like to call it, FLIP. That's us. My name is Maria Barenberg. I use she, they pronouns, and I'm the FLIP program assistant.
My name is Dallas Dunn. I use he, they pronouns as a part of the 2023 FLIP cohort.
I think we also have a couple other FLIP alum in the room, so hello, I see you. So Michigan FLIP is a summer residential program funded by the Centers for Disease Control and Prevention. We're one of 7 CDC John R. Lewis undergraduate public health scholars programs. The ultimate goal of FLIP and the Lewis Scholars programs is to increase the diversity of the public health workforce and the people committed to reducing health inequities. Through field placements, skill building workshops, and mentorship, FLIP provides students with opportunities for growth, learning, and awareness in the field of public health. Michigan FLIP involves a ton of community components, including the field placement experience, community service, and community-based research projects. Over the years, FLIP has worked with 87 total organizations in Michigan. So from between 2012 and 2024, FLIP has had 12 cohorts with participants coming from 242 colleges and universities. Ultimately, 202 FLIP students have gone on to work as professionals in a direct public health field. When we spread the word about FLIP, we emphasize that all majors are welcome and no public health experience is required to participate. We love to explore the intersections between different majors and backgrounds. We have some of them up here, but such as anthropology, history, education, and public health. And now I'm going to turn it over to Dallas to talk about their experience with the program.
Thank you, Maria. So while I was in FLIP, I completed a research project with some members of my cohort looking into homelessness in Washtenaw County and how it is currently addressed, and coming up with some recommendations for interventions to help improve that approach. In addition to that, we also completed a community health needs assessment where we surveyed people about what issues in Washtenaw County they believed most needed to be addressed. And then we used that to form a report with some recommendations that was presented to Michigan Medicine. And then so I completed a field placement with Habitat for Humanity where me and my fellow intern Kennedy, who also happens to be a student now at SVH, we helped to work with them to complete 2 exterior home improvement projects and a garbage pickup day for people in West Willow, Ypsilanti. And as part of those projects, we helped to create the list for the tools and go out and buy them. We worked with partners and members of the communities to help like figure out how to best go about doing these programs and making sure they're meeting the needs of the community. And then I also helped to create a flyer that ended up getting them increased engagement compared to their previous projects. And then ultimately got to present on it at the CDC. And that's my poster there. Overall, I would say Flip helped to increase my and give me some practical experience in public health, and helped me to learn from experts in the field and solidify my desire to come here and get my MPH.
Great, thank you so much. And now we have the legendary Barbara Israel.
Thank you, though. Okay, and this mic is still working too. All right. First of all, I want to thank all the presenters before me for staying on time and the timekeepers. I was convinced I wasn't going to get to talk because we'd already be an hour plus into the session. So, so now I have 10 minutes. No. I will try to, I've gotten it down to 5, so I'll try to see if I can do it today. Again, I'm just delighted to be here. I want to acknowledge my co-authors who are listed on this slide, the other participants of our CBPR Partnership Academy, which is the focus of what I'll be talking about, and other Detroit Urban Research Center colleagues who've been instrumental in this work, many of whom are here today. Special shout out to Chris Coombe, who has been the multiple PI on the Partnership Academy and has a real leadership role in this work that I'll be talking about, and Corey Jones, who helped with the slides, which is not my strong point. All right, and I also said before, people have probably figured out by now the slides aren't showing up on this screen. And one of my critiques of students in presentations is don't look back at the screen. You know, look at, and now I'm going to have to look back at the screen. But anyway, so apologies for that. Just a little bit on some of the rationale of why we got involved in the Partnership Academy. As you all know, Black, Indigenous, and people of color and low-income communities experience a disproportionate burden that impacts health inequities. Historically, these communities have not been involved in research, have often been harmed by research, haven't benefited from research, and it's resulted in increasing calls for more participatory approaches to research and equitable approaches to research. Community-based participatory research, or CBPR, is one such approach. And as support increases, so does the need for enhanced capacity to do CBPR. Most faculty aren't trained in that as a part of their graduate program, or community members. And in 2015, the Detroit Urban Research Center established the CBPR Partnership Academy. Quick turnaround. Okay. The Detroit URC, we're in our 29th year of a CBPR partnership. Those logos represented here, the community-based organization, health and human service agencies, and units here on campus. And our overall goal has been to foster and enhance the capacity of and sustain collaborative CBPR partnerships to focus on physical and social determinants of health inequities. The Partnership Academy, our overarching goal, has been to enhance capacity, knowledge, and skills, creating, implementing, and maintaining successful CBPR partnerships much beyond Detroit and University of Michigan. So it's a national program. The Academy has aimed to increase participation of researchers from underrepresented racial and ethnic groups, and importantly, it's been conducted by experienced Detroit URC community and academic partners, several of whom you've heard from today and are in the audience. The Partnership Academy has been a year-long program in which each year 12 teams, including a community and an academic partner from around the country, have come together. We've had 5 cohorts total for a week-long interactive program, course, online interactive forums, community academic mentoring, grant proposal development and implementation, and a community academic scholars program. They've been represented from 58 teams from 25 states, Washington, D.C., 3 tribal nations, and 70% from racial and ethnic groups that are underrepresented in research. The evaluation approach we've used has been participatory, informative, impact and outcome evaluation, process evaluation, use mixed methods. Don't have any time to go into all those details, but glad to share articles. And some of the results, participants have said they've enhanced their knowledge, skills to conduct CBPR, strengthened their relationships with partners. They value the co-learning approach that was used and benefited from the mentors, community and academic mentors. So some of the select accomplishments that these teams have gone on to do, they've received grants, they've conducted intervention and research that has improved health status and policy change. They've conducted workshops, courses, presented at professional meetings, community meetings, published articles, and have talked about the impact on their careers. And the few select lessons learned, just to highlight, has been that engaging both community and academic partners as both participants and trainers has really integrated CBPR and health and equity. It's been essential to do both applied learning as well as content focus. And I just want to close with a, does somebody up there can click on this since I don't have the screen? This is a quote, a video clip from one of our esteemed members of our 2015 cohort, who's now our very own Enrique Neblett, professor of HBHE and the new director of the Detroit Urban Research Center. So I'm going to turn it over to our tech people, maybe. Are you able to do it, or do you want me to paraphrase it?
Take the time, build the relationships, and from that, everything else will come. I come from clinical psychology is where my, sort of my training, and to have an opportunity to sort of leave my discipline and intermingle with other public health professionals and community professionals is a new experience for me. So I think this is really going to transform the work that I do and the way that I do it. And I'm really happy to have had this opportunity.
And I'm incredibly thankful that he's transformed where he works from UNC Chapel Hill to the University of Michigan. It's been quite a journey. And just close with, oops, there was a picture of all the 5 cohorts, but so thank you again. Appreciate it.
Alrighty, folks, thank you. Can we get another round of applause, please, for all of our speakers? We want to thank everyone for joining. The day is not over yet. We were able to hear some of the amazing work that's already being done, and there's more still to come.
We also hope that you are inspired today, not only to hear of the lovely things happening, but also inspired in your own work. We also invite you to join us for the reception next door, where you can talk with all of our presenters and also meet all of our poster presenters as well. It's a lot more work to be shared, so.
Yes.
I just want to do a quick thank you to Scott. This event was Scott's vision. It was his brainchild. He really is the one who made it happen.
Yes, and special shout out to the planning committee. Okay, we really did this. Yeah. So we have a minute until the poster session starts. I have to go to my poster, so please join us. We have light refreshments, mocktails, and hors d'oeuvres.